After that, we should know the impact of pelvic adhesions on infertility. The adhesions affect the infertility by distorting the normal anatomy and disturbing the motility of an organ like fallopian tube. It interferes with the movement of ova through the fallopian tube, so this leads to recurrent pregnancy loss or infertility after all. Adhesions showed statistically significant association with the primary and secondary infertility. What are symptoms of pelvic adhesions? The patient will come with us with chronic pelvic pain, sometimes painful ovulation, or painful intercourse. For some women, sometimes the infertility is the only symptoms she comes complaining from in the clinic. How pelvic adhesion is diagnosed? Pelvic adhesion is diagnosed by symptoms of the woman or by ultrasound, hysteroangiogram in the clinic, or but definitely the diagnostic procedure is laparoscopy. This picture shows how surgeon cut the adhesions with scissors. And we should know the difference between tubal blockage versus adhesions. It's important to distinguish the difference between them, whereas the blockage, the tube itself may be obstructed with scars or anything, and may have normal mobility, but the adhesions, the tube itself, it doesn't move, and this leads to recurrent mess of pregnancy and infertility. Some of major advantages of opting laparoscopy adhesolysis. It can be performed creating very small incision in the abdomen, and after all, it's less painful and less internal scarring, improved quality of life among women with chronic pelvic pain. It also requires shorter hospital stays and leads to quicker healing, as well as its comparatively early start of oral feeding and solid diet. This video shows how surgeon cuts the omental adhesions. It's for a woman like 35 years old, complaining from primary infertility for 6 years, and she has conceived after like 6 months from having this surgery. Also, at the end of this video, the surgeon will cut the adhesions that's between uterus and Bausch Douglas and the ovaries. And sometimes we notice that the adhesions is most commonly in the left side of the pelvis and the omentum. The objective of this study is to evaluate the ratio of pelvic adhesions in patients with primary or secondary infertility, and to assess the value of laparoscopic adhesolysis to increase chances of pregnancy. Material and methods. This retrospective study included like 165 women with the age between 23 to 45 years old, all with history of primary and secondary infertility. These patients had diagnostic laparoscopy in the period of time from November-December 2021 at الحياة clinic, and we found out that these patients, 111 from them, it's like 67% had pelvic adhesions during diagnostic laparoscopy, and 39, which represent 24%, had left side omental adhesions. And about like 36 women, which represent 22%, had conceived in the following 6 to 9 months. Conclusion. Laparoscopic adhesolysis is of great value to treat pelvic and periaxial adhesions and to efficient restoration of the pelvic normal anatomy, normal tube function, tube-ovarian relationship, and to restore infertility and achievement of pregnancy. Thank you.
Thank you, Dr. Rayhan Al-Gamri. Moving on now to our final oral presentation for this session. Could I please join to the stage Dr. Khulud Luhail. She has graduated from the University of Al-Khumus and she is currently enrolled in infertility diploma at the Arabic African University under the supervision of Professor Yusuf Gedmour and Dr. Na'mat Abed. Her topic is the pregnancy rate after operative hysteroscopy in subfertile women at Gedmour Fertility Center from 2019 to 2020.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. دكتورة خلود سنسلي حيو مستشفى الخمس التعليمي، حاليا في دبلومة العقم تحت إشراف دكتور يوسف قدمور دكتورة نعمات. زملائي في البحث دكتورة إكرام مرجان، دكتورة رنيم شتاوي، دكتور محمد سريح، سوبرفايز دكتور يوسف قدمور. Our study on pregnancy rate after operative hysteroscopy in subfertile women at Gedmour Fertility Center, Tripoli, Libya. Female fertility workup include evaluation of uterine cavity, which is pathology about 10 to 15% in subfertile women. The hysteroscopy has diagnostic and therapeutic role in management of infertility that related to uterine cavity. The polyp, submucous fibroid, septum, and intrauterine adhesion all affected reproductive outcome women due to effect on human embryo implantation. As we know, septate uterus is the most common congenital uterine anomalies, accounting for 35% of such anomalies. Uterine cavity pathology can be diagnosed with ultrasound, histosalpingogram, and MRI and hysteroscopy. The gold standard method for diagnosis of intrauterine adhesion or pathology is hysteroscopy. The hysteroscopic improved pregnancy rate in women with multiple implantation failure. So, what's the objective of our study? The objective to assess the effect of hysteroscopic removal of endometrial septum, polyp, submucous fibroid adhesion on pregnancy rate in subfertile women at Gedmour Fertility Center. Methodology, study design, retrospective cross-section study, duration from Jan 2019 to December 2020 at Gedmour Fertility Center. Database system for analysis using the statistical package for social science version 16 SBSS. Sampling during the period of the study, 291 women whose hysteroscopic intervention was done. The demographic profile include age, type of fertility, failed attempted before hysteroscopy, hysteroscopic finding, pregnancy outcome is spontaneous or ovulation or IUI or ICSI. Our result of this study, during the study period, 291 women were treated with hysteroscopy, 53 of them get pregnant, about 18.2%. This table shows the percent. Next table shows pregnancy rate according to age group, and we found the higher percent in lower age group from 18 to 25%, 25, about 30%. From 26 to 34, 23.8%. While 35 to 43, 10.8. The age above 43, about 0%. This show pregnancy outcome by previous failed attempted pregnancy. Sorry. It showed that patient without previous failed attempted had higher percent, about 23.6, while the another group about 14%. This table shows pregnancy rate according to type of fertility, and we found secondary fertility, subfertility, take percent about 23.4, while in primary, 13%. This table shows pregnancy outcome by hysteroscopic finding. We found higher percent in complete septum, about 21%, and lower percent in submucous fibroids and small septum together. In small septum lateral adhesion, about 19.6%, polyp and lateral adhesion together, 11.8, submucous fibroid, as we mentioned, 0, polyp and small septum, 8.7. Last table show pregnancy outcome by type of pregnancy induction. Is spontaneous or IOI or ICSI or ovulation induction. And we found the spontaneous pregnancy higher percent, 51, and in ICSI 36%, IOI 7.5, ovulation 5.7. In discussion, our results show improved reproductive outcome for women underwent operative hysteroscopy, about 18% achieved pregnancy. Now we will compare our study and other study. In our study, the septated risk, complete and small septum together, the percent about 40.6%, while in Sardogan, about 78.6. In our study, intrauterine adhesion pregnancy rate was 19.6%. In other study, the percent was 52%. Last one, the polyp pregnancy rate was 20.5. In other study, 63%. In conclusion, this study showed that there is effectiveness of hysteroscopic surgery in subfertile women who have uterine cavity pathology. Randomized control study can be needed for future evaluation. معلش سامحوني اخذ من وقتكم شويه. حابه نشكر صناع الامل. سعيده واني محظوظه جدا اني موجوده اليوم بين قامات علميه متميزه. حابه نشكر دكتور يوسف عدام دكتورنا العزيز. شكرا لانك انت اتحت لي فرصه اليوم نكون على الستيج. حابه نشكر دكتوره نعمه عبيد، دكتوره عائشه الزالط، دكتوره بروج عليمان، دكتوره ايمان ضو، دكتوره هنيده المجراب اكيد طبعا. ونقول لكم انتم كنتم مثل الاعلى ولا زلتم مثل الاعلى. شكرا.
Thank you. That was Dr. Khulud Luhail. We will now move on to our final oral presentation for this session. Could Dr. Iman Al-Fitouri please join me to the stage? She's a doctor of obstetrics and gynecology at Al Jalat Maternity Hospital. She's also a member of Professor Muhammad Dabous's team for minimally invasive gynecological surgery and reproductive medicine. She'll be talking about laparoscopic myectomy versus open myectomy in relation to the outcome and impact of fertility. Stage is all yours.
Thank you. Good morning. Thank you, Group Noor Al-Hayat, to give me this opportunity to present my first research paper. It's about uterine myoma. My doctors, my colleague, let me start with the first slide, which is the title of the research. My research is about laparoscopic myomectomy versus open myomectomy in relation to outcome and impact on fertility. The first, I would like to start with the introduction of the uterine fibroid. So what is uterine fibroid or leiomyoma, and who commonly found, originates from which layers and which size, number, and types? The uterine fibroid actually is a common gynecological disorder. It's one of common gynecological disorder, and it's a benign tumor which arises from the overgrowth of the uterine smooth muscles, and it has the most common benign pelvic tumors with a prevalence rate from 4.5% to 68.6%. Commonly found in women in reproductive age, and number of the fibroid ranging from one to multiple, single or multiple fibroid. The size are ranging between 1 centimeter to more than 20 centimeter, and the types of fibroid are titled according to its locations. The etiology of fibroid and the risk factors. Actually, the etiology of fibroid, the etiology of under the development of the fibroid is unclear, but it has many risk factors to develop this disease. The risk factor includes age and race, family history and genetic factors, nulliparity and obesity, and also some resources mentioned that hypertension is a risk factor for to development the uterine fibroid. Like NCBI guidelines mentioned that elevation in the systolic blood pressure 10 millimeter mercury can increase the risk of uterine smooth muscles injury, which lead to a risk factor for a uterine fibroid. So here, the patient with uterine fibroid may be often asymptomatic. Only 25 to 50% of patients with uterine fibroid are symptomatic. The symptoms may reveal heavy menstrual bleeding and cramping, pelvic pressure or pain, urinary frequency, pain during the intercourse, or maybe the only symptom of the patient is swelling or enlargement of the abdomen. This clinical presentation or symptoms are different according to the type, according to the location and size of the fibroid. Actually, a month ago, I saw a patient has only symptom that is swelling and enlargement of the abdomen. The abdomen was reaching the umbilicus and diagnosed as multiple uterine fibroid. Okay, I would like to ask a question here. Does fibroid impact on fertility? The answer will be yes. Myoma are present in 5 to 10% of infertile women. They present as a sole cause of infertility in 2 to 3% of patients according to NCBI guidelines. So the impaction of fibroid infertility that according to its type and location. The first, submucosal fibroid that lead to distortion to the endometrial cavity and lead to interfere with implantation. Previous research has linked intramural fibroid to defective in implantation as well as to an abnormal peristaltic event of the uterine smooth muscle. And also the tubal ostia could be obstructed by the fibroid and do an impairment to gamete transport. Actually here, subserous leiomyoma has no leading for impaction on fertility just like the other types, but subserosal myoma may be pedunculated. The pedunculated type may can cause compression on the pototubes and may lead to risk factor as a fertility and consequence on pregnancy. On the other hand, the fibroid can lead to consequence on pregnancy. It leads maybe to recurrent abortions and maybe a preterm labors, and some types of fibroids are risk for cesarean sections. So here, treating the uterine fibroid is with a surgery called myomectomy. the recommended first line to treatment for the uterine fibroid. The recommended treatment of fibroids depends on the patient age, the type and size of fibroid, the severity of the patient's symptoms, and whether the patient plans to conceive. The fertility-sparing qualities of myomectomy make it an excellent option for women experiencing fibroid-related infertility. Some studies referred that myomectomy has increased the rate of pregnancy from 25% to 42%. So here we have two surgery. We can do myomectomy as open myomectomy or laparoscopic myomectomy. Each surgery has advantages and disadvantages. We want to start here with the open myomectomy. This is the traditional laparotomy surgery. Has advantages and disadvantages. The advantages that performed by the traditional laparotomy incision, which can performed with any gynecological surgeon actually, and it has a short procedure time. Open myomectomy is preferred in multiple and very large and deep fibroids compared to laparoscopic myomectomy. Disadvantage of open myomectomy, the opening or this incision lead to an irritation to the peritoneal wall that can precipitate an increase in the inflammatory mediators, which could result higher febrile condition. More blood loss here in comparing to laparoscopic myomectomy and longer hospital stay. More pain in the first 24 hours and longer recovery time. So here, the laparoscopic myomectomy also has advantage and disadvantage for this procedure. The advantage of laparoscopic myomectomy, it's a minimal invasive surgery that has a small incision measurement by only one finger or 1 centimeter. Lower intensity of post-operative pain during the first 24 hours in comparing to open myomectomy. The third thing is the shorter length of hospital stay and recovery time in comparing to open myomectomy. The disadvantage here for laparoscopic myomectomy, actually it's a technical procedure in comparing of the open myomectomy. It needs a long procedure time. It may take 2 hours to be performed. And it needs an experienced surgeon. It needs high accuracy and concentration due to the time and due to its performance by laparoscope. Actually, the last one is lack of equipment that we must aid it, like as in our country, actually. So here a patient is 36 years old, bara 0+2, history of secondary infertility 3 years, diagnosed as a single intramural myoma with measurement 6 centimeter to 5.7 centimeter. The only symptom was a heavy menstrual bleeding. The patient has myomectomy in the last August in 2021, and after 7 to 8 months, patient got pregnant, and we are so glad for that. So that's the reason for the myomectomy, and that's the reason for myomectomy and to treat the myomectomy. So treatment of myomectomy, we said that it's related to the type, related to the size, and the ability to conceive. Our objective study for today is a comparison between both types of myomectomies was in terms of hemoglobin drops, hospital stay, fertility outcome, and also clinical efficacy was also compared 2 weeks after surgery. Material and methods in this study includes, this retrospective study include 95 women with a history of infertility related to fibroid. Their ages range between 30 to 45 years, all with uterine fibroid, either single or multiple, have size range between 3 centimeter to 9 centimeter. 52 women had an open myomectomy as enrolled in the group A. On the other hand, 43 women had laparoscopic myomectomy, which include in the group B. This is study done in the 1st of January in 2022 and in the last of December 2021 and end to the last of December 2021. The result of our study is like this is a chart with 2 columns. The red one represent laparoscopic myomectomy and the gray one represent open myomectomy. So we made a comparison study for this patient between laparoscopic and open. According to hemoglobin drop more than 1 gram per deciliter, actually laparoscopic myomectomy patient has only 20.9% of patient has an hemoglobin drops more than 1 gram per deciliter pre and post-operative. Comparing to laparoscopic open myomectomy, that it is hemoglobin drops more than 1 gram per deciliter, reaching 57.7% of patient. Some patient was has an hemoglobin loss, hemoglobin drops more than 2 centimeters according to the location and size, number of the fibroid. So the second thing is the time of the day of discharged. 93% of patients with laparoscopic myomectomy discharged on day 1. Either no patient in open myomectomy discharged on day 1. 6.9% of patients with laparoscopic myomectomy discharged on day 2. On the otherwise, all patients with open myomectomy discharged on day 2. So, and fully recuperated patient after 2 weeks in laparoscopic myomectomy, 93% of patient has a fully recuperated after 2 weeks, in comparing to 73.1% of patient with open myomectomy recuperated after 2 weeks and more. So, the increasing the rate of infertility of pregnancy here in fibroids depending on the size of the fibroid, the location, and the operation. Sometimes more suturing lead to needing for more recovery time, and then we should give the patient more time to conceive. Here, patient with increased risk of pregnancy in laparoscopic myomectomy has reaching 18.6%, comparing to laparoscopic myomectomy with 15.4% getting pregnant. So, conclusion of our study, as laparoscopic myomectomy was associated with higher rate of pregnancy than that following open myomectomy, less hemoglobin drops, reduced operative blood loss, more patients fully recuperated in day 15, and the mentioned post-operative pain and fewer overall complication. Noting that laparoscopic myomectomy has achieved the superior result to open myomectomy when it has been performed by an experienced surgeon. Our study actually supported with RCOG guidelines that mentioned laparoscopic myomectomy is the keyhole surgery for treatment of myoma. And RCOG guidelines listed the uses of morcellation benefit in laparoscopic myomectomy for less blood loss and less recovery time, less risk of infections and less risk of blood clots in the lower limbs and lung. On the other hand, we have the second guideline that support our study, which is ESHI guidelines. ESHI guidelines recorded that laparoscopic myomectomy is a low risk of adhesion compared to open myomectomy in post-operative patient. The second thing, ESHI guidelines mentioned that laparoscopic myomectomy need an experienced, skilled performance surgeons, and it needs supportive medical equipment. Thank you for your time. Thank you for your attention.
Thank you, Dr. Iman Al-Fitouri, for that intriguing presentation. We would like to conclude our session today with a discussion. We would like to open the floor to any questions or any remarks. Our panel will be governing the session. If anybody has a question, could they please raise their hand?
Start by the first speaker, Dr. Yusuf. Dr. Yusuf addressed hysteroscopic uterine septum resection. If there is any question for Dr. Yusuf, Dr. Muhammad Salam Agad.
The nice talk, Professor Yusuf, but the new guidelines regarding the deal with the septum concentrate in two things. Number one, we have to differentiate between it is a primary infertility diagnosed after a previous pregnancy and delivery, or it is a type of secondary infertility. In secondary infertility women, no need to interfere at all, full stop. As regard a septum with primary infertility, it is a debate between you and the patient, depending on the duration of pregnancy and the history of failure of such pregnancies, even with ART programs. My question for you, you advise circulage after septum removal by any means?
Thank you for your comment and your question. Concerning primary or secondary infertility, as we said, it is highly recommended to do a metroplasty or resection of the symptom in the primary subfertility. Prove it. However, I mean, some cases, this case, which she has one child, sometimes the symptom is not central, and she can conceive in the other cavity, but then by chance the other all other pregnancy comes to the other side, which is maybe small or so and so. Even in that case, I think you have to remove the septum. This case which I show you, she had one child and then 5 or 6 abortion. And I did all investigation for recurrent abortion, all were normal, except I found this is a large septum. So I think still there is room for, even for secondary subfertility.
Soundly indicated for to do, to resect the septum in this condition.
Yeah.
He's asking about the
about
circulage.
the circulage. I don't do circulage for every patient. As you know, if there is two cervix, and you cut them, like the other case, maybe in that case, maybe better if you do circulage.
And also the guidelines not recommending to do circulage in cases of uterine malformation. Dr. Abu Hafiz has a comment.
Yeah, I've just a comment about uterine septum and the diagnosis of septum nowadays with the transvaginal ultrasound. Even the hysterosalpingogram, they have dimensioned role. I mean, if you don't have or you are not good in the transvaginal ultrasound, you may use the hysterosalpingogram. Otherwise, better to use the transvaginal ultrasound. The other thing, when we are going to do the septum, we don't need to do laparoscopy. This is an invasive procedure. The patient doesn't need it if you have diagnosed the septum. Nowadays, nobody using the IUDs. It had been used in the last era when we have been using lip sloop. Even now, there's people whom they want to use the device, they are using the cover and they remove the wire from it. But there's no scientific-based evidence to use the other thing which I want to mention, if a woman, she came and she have a septum had been done, it doesn't mean she needs to deliver by cesarean section. She can deliver normally. Thank you.
I quite agree with Dr. Abhafiz, and if you don't have 3D ultrasonography, the alternative is sonohysterography and not hysterosalpingography. Yes? Mike, please.
Thank you, Dr. Yusuf, for your presentation. Just to continue from what mentioned by Dr. Abdelhafid, my concern about laparoscopy. I usually don't do laparoscopy for these cases, but you mentioned that you do laparoscopy to see how far you are dissecting the septum, which is, again, you cannot get benefit from laparoscopy. What I find it benefit is using ultrasound guide, abdominal ultrasound, that will help you more to see how far you are going. Thank you very much.
Can Dr. Yusuf answer, please, or reply?
Yes, actually, I'm not doing laparoscopy just to see is the fundus like that or how far he is deep, but as a kind of investigation to see, I mean, in those cases, maybe I do drilling, maybe I look for patency of
Drilling? What is drilling?
Of drilling of the ovaries. Because
No,
maybe case of
this is
PCO.
no indication. Yes.
No, because this is a case of infertility, come to me. So I have to do full investigation. I will see tubal patency. Sometimes I'm doing that just to see the tubal patency or to see if there is endometriosis or if she has BCO, large BCO, maybe I do drilling. So I'm doing the laparoscopy for other things, and at the same time, I will see the fundus, how it looks like.
Shukran. Yes, last one.
I want to ask حياة.
حياة. طب would you please one by one يعني هناخد بعد كده بعد إذن حضرتك الدكتورة إيمان الفيتوري. Her talk was laparoscopic myomectomy versus open myomectomy. Where is Dr. Iman? If there is any question or comment for Dr. Iman. Yes, Dr. Muhammad.
Evidence-based myomectomy. What is the rule? It will depend about the availability of the laparoscope and the skills of the surgeon. Why? Because the outcome of pregnancy versus you mentioned is the same, either by laparoscopy or by traditional laboratory. This is number one. Number two, laparoscopy in myomectomy, if it is isolatory, everything will be nice. But if you have multiple myomectomy, there is a limitation. But any one of us don't deny the value of endoscopic surgery in the form of the stay, rapid recovery, many things like that. Thanks, Doctor.
Dr. Iman, would you reply, please?
Good morning, Doctor. The first question was about the laparoscopic myomectomy with an experienced surgeon.
Dr. Muhammad asking you about the reproductive outcome. That's to say the rate of pregnancy. You mentioned it was 18% in case of laparoscopy, and in open it was 15%. And I can add, you didn't do statistics to see if this statistic is significant or not. 15 and 18, it may not statistically significant, right?
Yes, but because this is a closed study for only unlimited patients for myomectomy, having a myoma, even if it's healed with laparoscope or open myomectomy. So I think this is a small study, like the statistic study will be later for
Shukran.
that.
Dr. Abhafiz has a comment.
It was a nice presentation. You asked the question about the myomectomy and infertility. I mean, we are not doing a myomectomy for every patient.
Yes.
And you have, because you see, this is, again, it's a very invasive procedure, either open or laparoscopy. Therefore, a patient who doesn't need it, we don't have to do a myomectomy because she is infertile. I want to ask you a question. What do you do about morcellations? Are you sure that the patient is not having sarcoma at changes or malignant changes, and dissemination of how you do to avoid that?
Mike, please.
Okay, I can answer. Actually, the first question is ongoing studies, small studies, small numbers. We are just starting with. We have just to present our result. It should be wrong. It should be right. It's ongoing study. The second question. Yes, we have here. We have beside you Professor Amhaishi. I think he is. The surgeon #1 of myomectomy. He done, I think, thousands and thousands of myomectomy in Libya. But I think every day he do like 5, 6 operation myomectomy. Yeah, that's why this is in mid-training areas is a little bit okay accepted number in Nur al-Hayat clinic. The second question for the morcellation, the risk of presence of leiomyosarcoma is very rare. So there is a criteria if by history, if the increasing in the size of myoma in short time, so we suspect it can be, or there is a possibility of cancer, leiomyosarcoma going to the open surgery, but the percent is 0.05. So we do immortalization for them.
What are the precautions? How will we be sure that the chances are very small of their malignancy?
If there is
Morcellating a fibroid and there is some malignant cells, that means we are going to disseminate it all over the peritoneal cavity. Beside the history, apart from the history, what are other precautions you are usually doing for those patients? You know, just tell you, I mean, some or many countries now, they ban doing laparoscopic myomectomy for this reason.
Abandoned the morcellation, not laparoscopic myomectomy.
No, not because of the morcellation, because this is the way. This is one of the way of delivering the fibroid, but there are other ways.
We want to ask you about the way of removing or delivering the fibroid in your cases.
We're using.
أنا old-fashioned معلش يعني. I have a lot of seal of myomectomy, but my regulation that single myoma and not deep. Yes, I can go for laparoscopy, and you can use morcellator, why not? Or you can take it, even open and do it. In multiple myomectomy, in multiple fibroid, I think people even, they go fast, but we go back. No way. You have to do laparotomy, clean, buried your stitch, observe. The question I want to ask, how long you give time, what the time give to the patient to get pregnant? Especially when you be in a mess of myomectomy, and how long?
Yes.
You don't be happy if she next month come pregnant.
No,
that would be disaster.
Yeah, this is
because
a disaster.
You might
yes.
have a ruptured uterus.
Yes.
And even in hysteroscope, maybe Dr. Gadmoor, if he can't find the limit, and the limit easy. You can sight by the hysteroscope. When you get small holes start bleeding a little bit, stop. No need to do laparoscope. But if you go deeper, you'll end by rupture uterus once you get pregnant. So you have my policy, if multiple give 1 year.
Yes.
If even 1 or 2, usually 6 months. Don't induce for pregnancy.
No.
And thank you.
Just a comment, we are not inducing any ovulation after myomectomy. Just we inform the patient to wait at least 6 to 12 months, but the patient is pregnant, so.
Yes, if there is any questions for Dr. Iman? Yes? Mike, please.
Good afternoon or good morning. Because I'm epidemiologist, a little bit away from your specialty, I have two quick comments. One comment regarding the design of this study. I like very much what they did because from their methodology, they have defined that this type of study is a descriptive study. So we cannot ask them to do comparison between the results because this is the design. The design should be before you start your work. This is the first comment. Second comment, I'm very supportive for my teacher, Dr. Gadmour, and Dr. Mohammed Abu Dabbous, because we need to activate the researches and database and the basic information in our country. I'm very supportive and very happy. Thanks.
Doctora, you mean the descriptive or the observational study, there is no need for statistics?
You need descriptive statistic.
Yes.
Descriptive statistic, they have done that already. They did the mean, they did the percentage. This is the descriptive. You ask it for comparison. If you will go for comparison, this is not descriptive. This is my comment. So they were strict to their methodology.
Shukran.
Thanks.
We can shift to the next speaker. It was Dr. Rihana Al-Gamri, and she addressed pelvic adhesions related to infertility. Dr. Rihana.
عفوا يا دكتور. نبي.
Yes, Dr. Yusuf.
Just I have a comment about the previous speaker, this myomectomy or not myomectomy. I just comment that many cases had myomectomy unnecessary. And many cases I see them, they are infantile because they had myomectomy. So don't rush quickly for any mass in the uterus. Come and do it. This is the result. This is the reason for infertility. You have to investigate completely. Then you decide, does she need myomectomy or not myomectomy? But actually, I see a lot of cases twice or 3 times for myomectomy, and that's the reason for her infertility.
Shukran, Dr. Yusuf, for this comment. Again, the Dr. Rihana, Dr. Muhammad.
As we know, pelvic adhesion etiology, mainly 2 factors. Number 1, incompletely treated BID. Number 2, the surgeon, iatrogenic. We are the creator, even with D&C for Asherman syndrome. So prevention is better than cure. My question for you, Dr. Rihana. After adhesolysis, laparoscopic adhesolysis, did you advise the use of adhesion barriers or not? يعني
Dr. Rihana.
Dr. Rehan, she's not present at the moment.
مشت.
دكتورة، دايما بعد السقاط بنحط عوائق علشان ما يلزقوش الرو اريا، ما تلزقش تاني. في الدراسة بتاعتك بتستخدموها ولا لا؟
yes or no بس.
May I answer?
ما بتستخدموهاش خالص؟
So she didn't
هي
use any post-operative. We can, my comment for you, the incidence of adhesion is very high, about 67%. We should know the explanation. And when you described it, you didn't, you tell us only about left or lateral. This is of no value. The most important, what's the site? It is tubal, it is ovarian, and also what's the severity? It is flimsy adhesion or it is marked adhesion. This which will affect the reproductive outcome, not left and right.
One very important comment. I've seen the video which she presented. That's good. But I was very scared from doing adhesolysis with the monopolar. Now, if we want to do a monopolar adhesolysis, I mean, we have to be very careful because of the late effect of the. If you have to, you may use the bipolar instead of monopolar.
ممكن يعني.
Second, fully agree with Professor Budher. That video is not monopolar. This is bipolar seizure. I'm very happy that Nur al-Haya have a bipolar seizure. Omentum adhesion, maybe it's not affecting the infertility. It's far away from the ovaries and tube, but the continuance of the video was deep down in the pelvic room, was textilomas. Forgetting goes inside the Douglas. We are not using monopolar electricity unless at indication, maybe in myomectomy or in total laparoscopic hysterectomy. Caesar bipolar, we have it.
Shukran. The last speaker.
Just one
Yes.
point. I am not with you in giving any anti-adhesion liquid or gases.
Yes.
This is the etiogenic adhesion, what Dr. Muhammad said. So you have to be neat surgeon with the laparoscope, with a scissor, and stop any bleeding. Then clean it with ringer or normal saline, and then after see it and let me know.
Yes, that's right.
Excuse me, Dr. Bakr.
The same.
Yeah, the same.
احنا نسينا حضرتك. لا
No,
لابد.
he's next speaker.
لا.
Regarding myomectomy adenolysis, both, I think for our future generation here, they must, this is practical points, okay? And as an infertility specialist, if we are looking about adhesions, you are concerned with certain point related to pregnancy.
Yes.
I'm not concerned about omental adhesion with anterior abdominal wall.
Yes,
It's nothing to do
yes,
with my
that's right.
patient. My
Yes.
patient wants to get pregnant.
Yes, that's
I
right.
am concerned with fimbria.
Yes.
Where is the fimbria?
Yes.
Where is the
Yes.
ovary? The pickup ovary, number
Yes,
one.
I
okay?
quite agree with you.
Yeah,
Right.
so this is a practical point for our future
Yes.
generation. We
Yes.
don't concern with any adhesions we can see
Yes.
as an infertility specialist.
Exactly.
Myomectomy, I am as infertility, this is my ISHRI guideline and all over our college guideline. We are concerned with fibroid which interfere with the pregnancy.
Yes.
Mucous fibroid mainly. And if you do open surgery, many times you open the cavity. What I am concerned as infertility specialist, to close this cavity properly. You never ever can be done by laparoscope.
Yes.
Don't cheat yourself. That's my
شكرا.
advice. Thank you.
Because we have behind the schedule. Yes, دكتور. حضرتك لا اديله لو تكرمت كده لان احنا بيقولوا لنا خلاص تعديتوا الوقت بتاعكم.
ما يكونش انتوا خلود if it is possible.
من عينيا حاضر. حاضر. لا اتفضل.
ما يكونش انتوا خلود if it is possible. خلود.
خلود.
Yes.
اتفضل. The last speaker,
Yes.
خلود,
Yes.
she addressed the pregnancy rate after operative hysteroscopy in subfertile women.
As
اتفضل.
we know that the pregnancy rate after in ICSI after 42 years old declined dramatically. And I show us a slide that they do septal resection 44 to 48. So why they put the patient in the risk of this operation?
Yes.
That's business wise.
دكتورة خلود. She is asking about you did one patient and her age was above 40. Why you operated on her in this condition?
في الحالة هذه كنا نحاول إن احنا بحكم إن هي كاينة عندها infertility فنديروا أي شيء أو نديروا البروسيجر هذا الهيستروسكوبي ممكن إنه هو يصير لها بريجنانسي. أعتقد هيك سؤال؟
Yes, شكرا.
Um,
دكتورة سعاد اتفضلي.
It's not a question, it's not a comment, but I would like to thank Dr. Yusuf Gadmour and Dr. Budabous for giving a chance to the new generation.
Yes.
To review the outcome of their surgery, collecting the data, analyzing the data, and coming out with a study, and standing here in front of the audience in Noor al-Hayat conference and presenting their study in a nice way. Most of them, this is first time to stand in front of a large number of audience, and they did very well. Thank you very much. Thank you very much.
We are appreciating what is done by Dr. Abu Dabbous. The team approach is very important, and we are encouraging the other leaders to do this. Shukran. We came to the end of this fruitful session. I would like to thank the speakers and my co-chairman, and we will shift immediately to the next session.
Thank you, doctors, for that fruitful and healthy discussion. We're moving on. We'll move to our second session for today. The session will discuss the major theme of reproductive medicine. I would like to call upon to the stage Dr. Aziza Al-Gaddafi, Dr. Suad Al-Majrood, Dr. Sahar Abdul Rasool. Our first keynote speaker for this session will be Professor Abu Bakr al-Nashar, coming from Egypt. He's a professor of obstetrics and gynecology. He's also a chairman of the Clinical Obstetrics and Gynecology. His topic will be debating neglected factors of infertility. Could you give us a warm welcome, please?
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee for inviting me for this prestigious conference. You can find this lecture and more than 500 lectures on my scientific page on the Facebook Abu Bakr al-Nashar lecture for free download. And if I asked you what are the causes of infertility, the causes of infertility are 5. The male factor, the endometriosis associated infertility, the ovarian factor, the tubal factor, and the uterine factor. But we have other factors of infertility, and these factors may be important, and sometimes it is neglected. And that's why we will discuss today the neglected causes of infertility, or the factors which increase the time to pregnancy. We have a lot, but we will discuss today. It is not working. اللي عايز يغير الحجاره ولا ايه؟ ولا انا بضغط؟ Yes. I will discuss the advanced maternal age, the coital timing away from fertility window, the lifestyle, environmental factors, subclinical hypothyroidism, and lastly, niche. Let us start by the advanced maternal age. And it was found above the age of 35, fertility decrease. And the most important factors for decreasing fertility are the decreased quality of oocyte. About 60% of oocytes, there is aneuploidy. This is the most important factor, is the quality of the oocyte, not the number of oocyte, which is the second cause of increase the maternal fertility above the age of 35. The last is increase the miscarriage rate. And that is why we should advise, and this shows with age, there is a decrease in the number of follicles, and there is increase in the proportion of poor quality oocyte. لا ده كده مشكلة بقى. حط في حجارة أو تقول لي أوجهه ناحية إيه؟ فين أوجهه على إيه؟ أهو أنا بتك أهو، بس مش هشاكل معاه يعني. كده؟ المفروض ان اللابتوب يبقى قدامي هنا ما يبقاش عند حضرتك. So our advice for the married woman not to postpone childbearing, and for the single woman to advise her for cryoobservation of oocyte, what is called social egg freezing. لا كده مش معقول. معلش بقى. لا بيلعب. شكرا. And also we should ask for ultrafolic count above the age of 35 to know what the ovarian reserve and to be very active in management of the cases above the age of 40 or 35. The second factor is what is called coital timing away from the fertile window. What is the fertile window? It is about 1 to 6 days. The start of this window is highly variable, unpredictable, but the end of the window is well known. It is the end on the day of ovulation. And as we see here, there is the maximum fertility about 1 day before the ovulation. And this is the fertile window, as I mentioned, 1 to 6 days. The start is unpredictable and variable, while the end is with the end of ovulation. And this is the relation between the timing of intercourse and ovulation. If the intercourse ovulation interval 5 days before ovulation, the fecundability is 10% only. If it is 2 days before, this is the peak. But if it is 1 day before, great fecundability. On the day of ovulation, if intercourse occurred, start of decline. But when it is 1 day after ovulation, the conception rate is 0. May one ask why? First, because the short survival time of the oocyte, it is only 48 hours or 24 hours. But the most important factor is the closure of the gate, the swift change in the nature of the cervical mucus, preventing any sperm to ascend up. That's why fecundability, what is fecundability? Fecundability is the proportion of pregnancy within 1 menstrual cycle, and for normal couple it is about 25%, and fecundability increases with frequency of intercourse during fertile period. The third neglected cause of infertility is the lifestyle factor. And for the lifestyle factor, we'll discuss first diet, obesity, according to the ASRAM, very recently in 2021, is associated with decreased fertility rate. And this is attributed to the ovulatory dysfunction associated with obesity, the reduced ovarian responsiveness to the ovulatory drugs, and the alteration in the oocyte, and also in the endometrial function. All of these will lead to increase the risk of infertility. It was estimated that body mass index above 29 kilogram per meter square is associated with a natural consumption decrease by 4% per kilogram per meter square. And according to this author, obesity is a significant cause of infertility. And the TTP, the time to pregnancy, increased twofold in cases of obesity compared with the average weight. Not only the other side of is the underweight, and it was found that with underweight, the time to pregnancy increased fourfold. Some diets have a negative impact on fertility. The trans fatty acids, the meat, the carbohydrate, and also the elevated blood mercury levels from heavy seafoods consumption, all of these will increase the risk of infertility. The third for the diet is the vitamin D deficiency, and it was found that serum levels was significantly higher in fertile subject compared to infertile one, and there is a significant association between serum level and sperm motility. Are we going to screen for vitamin D? Let us see what are the recommendations of the respected guidelines. The screening for vitamin D, it is expensive test. And let us go to the Italian Association of Clinical Endocrinologists in 2018, recommending that a screening for vitamin D deficiency only in person at risk, only to screen if the patient at risk. And there is no benefit of screening healthy people. What are the indications according to this Italian association? Pregnant and lactating women, if there is a short interval between deliveries, obese, people not exposed to sufficient sun exposure after bariatric surgery, if any drug interfering with vitamin D metabolism, and also they recommended for screening for vitamin D in polycystic ovary syndrome. But there is another view. The Central and the Eastern European expert consensus advised any patient planning pregnancy, we should supplement her before pregnancy with vitamin D. And the recommended dose is 400 international units. So, as we know, for any patient who wants to get pregnant, we should supply her with folic acid. And the dose is 400 microgram. So, 400 microgram folic acid and 400 international units vitamin D. Not only this, but according to the recent guidelines of the Royal College in 2022, the deficiency of vitamin D is a possible cause of recurrent pregnancy loss, and vitamin D supplementation is recommended in this condition. The second lifestyle is smoking, and it was found that the effect of smoking on the woman, the relative risk of infertility increases by 60%. And the menopause occurs on average 1 to 4 years earlier. And there is increase the risk of miscarriage. What is the effect of smoking on the men? Decrease the density and the motility and increase abnormalities in sperm morphology. So we should ask her to stop and her husband also to stop smoking. What's about the caffeine? It was found that more than 250 milligram per day, the fecundability will decrease 45%. For 250, that's to say 2 to 3 cups per day. What is about the alcohol? It was found that more than 2 drinks per week is associated with increase the risk of infertility by 60%. The fourth cause is the environmental factors. For the women, toxins and solvents, which is used in the dry cleaning and the printing industries, is associated with a relative risk of infertility increase 40%. And the endocrine disrupting chemicals will increase the time to pregnancy. For the men, heavy metals is associated with abnormal semen parameters, and pesticides, lead, industrial microwaves, all are best avoided or minimized. What's the fifth factor, which is subclinical hypothyroidism? By subclinical hypothyroidism, the patient is asymptomatic, but the TSH is elevated while the free T4 and the free T3 are normal. Subclinical hypothyroidism is associated with ovulatory dysfunction in about 5 to 15%, and also is associated with infertility, but the incidence is different according to the cut-off level. Some considering the cut-off level for the TSH 3.7, others 4, and others 4.5. But it was found that higher normal TSH levels in women with unexplained infertility compared to infertile controls. Are we going to screen? The answer, yes. Please, any patient wants to get pregnant, we should ask for TSH. This is recommendation of the ASRAM, and in this condition, eltroxin should be given, and this will be associated with increase in the pregnancy rate by 44%. We should know what are the indications for screening of the thyroid dysfunction. Number one, as we mentioned, infertility. Number two, before IVF. Number three, repeated miscarriage. Number four, ovarian dysfunction. Number five, menstrual irregularities. And number six, if we have hyperprolactinemia. This is very important indication to screen for thyroid dysfunction. And how to manage? This is the guidelines. If we have a TSH less than 2.5, no further action. But if it is from 2.6 to 4, we should ask for the thyroid peroxidase antibodies. If it is positive, we should start eltroxin. If it is more than 4, we should start eltroxin immediately. If you didn't do the thyroid peroxidase and the TSH is more 2.5, you should start eltroxin. The sixth and the last neglected cause of infertility is the niche or the cesarean scar defect. As we know, it is iatrogenic. It is caused by the doctor, by the surgeon. Pouch-like defect at the site of previous cesarean scar due to defective tissue healing. The prevalence up to 70%. And the prevalence depends on the method of diagnosis. But we should keep in mind there is underestimation of the incidence of cesarean scar defect. And this is attributed to because it is asymptomatic. And also, many clinicians are unaware of the niche as a cause of the symptoms. There is the cesarean scar defect incidence is increasing with increase the number of previous cesarean section. And there is, it is underdiagnosed cause of secondary infertility. We should keep in mind if we have a patient suffering from secondary infertility, it may be, and there is a history of cesarean section, it may be due to niche. Let us see the relation between, first, the clinical presentation. Most are asymptomatic and only symptomatic in 30% of cases. It may be in the form of bleeding, pain, and today we will discuss secondary infertility and the causes of secondary infertility associated with the niche, and also the problems in IVF. Difficult embryo transfer in 20% and the failed IVF. May one ask, what is the cause of secondary infertility in niche? Number one, chronic endometritis by the residual blood. Number two, the peri-ovulatory fluid accumulated, interfering with sperm penetration, fertilization, and implantation. When we have a large niche, it will act like a hydrosalpinx, leading to hydrometra. And there is a very recent study relating the presence of niche with endometriosis. And this author, Barry, found that there is increased risk of endometriosis within the niche. And that's why he advised wide excision of the margin, which may be a cause or a contributor to the tissue weakness and niche formation. What is the effect of niche on the IVF? During controlled ovarian stimulation, intracavitary fluid is present in 40%. So special attention to exclude the fluid accumulation, particularly at the time of embryo transfer. And also, as we mentioned, it is associated with 20% difficult embryo transfer due to the distortion of the anatomy, especially if we have RVF uterus. Lastly, the effect on the RVF, it is attributed to chronic endometritis and the presence of the intracavitary fluid. And this recent author stressed on one important thing. It is the presence of the intracavitary fluid, not the niche. That's to say, if there is no intracavitary fluid, this will not affect the pregnancy rate. To come to the management, we should know what are the indications of management. We should manage only the symptomatic women with persisting symptoms, suffering from secondary infertility, as I mentioned, abnormal uterine bleeding, post-menstrual spotting, previous scar ectopic, recurrent miscarriage. And you want to lay stress that routine repair of incidentally diagnosed niche with no plans for future childbearing is not recommended. She don't want to get pregnant, so there is no need to treat her if she is not complaining and it is asymptomatic and accidentally discovered. This is an algorithm for the management of niche. If it is asymptomatic, no treatment. If symptomatic, we should ask, there is a reproductive desire or not. If there is a reproductive desire, the gold standard of treatment is laparoscopic or vaginal approach. If there is no reproductive desire, the gold standard is hysteroscopic, provided that the residual myometrium is more than 3 millimeters. To come to the conclusion, neglected causes of infertility are advanced maternal age, coital timing away from fertile window, lifestyle, diet, obesity, underweight, vitamin D deficiency, smoking, more than 250 milligram caffeine per day, more than 2 drink alcohol per week, environmental causes for the female, toxins and solvents, endocrine disrupting chemicals. For the male, heavy metals, pesticides, lead, industrial microwaves, subclinical hypothyroidism, and niche. Shukran.
Thank you, Professor Abu Bakr al-Nashar, for that insightful presentation. Moving on to our next keynote speaker, Dr. Umayma Abu Ghrara from Libya. She's a specialist in obstetrics and gynecology. She has over 14 years experience in obstetrics and gynecology. She has a membership in the ISUJ. She also works at Noor al-Hayat Center and the Masarra Center. Her topic will be talking about the role of 3D vaginal ultrasound in diagnosis of a uterine anomaly.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'm honored to be here in front of you. I thank Dr. Abdelaziz and Dr. Salma Msellati to give me this chance to be with you today. Today we are talking about something is very good to assess the infertility issue. Role of 3D vaginal ultrasound diagnosis of uterine anomaly. First of all, I start my lecture with this picture. I think this is all what we know about uterine anomaly. I think this is all what you know about uterine anomaly. We will start one by one about how to diagnose by 3D. First of all, we have to know advantage of 3D over 2D. P-side or offline analysis, off-site expert consultation, data is easily revisited for additional evaluation, short processing time, affecting teaching tools, stimulating real-time scanning. First of all, we have to speak about Mullerian anomalies. According to American Fertility Society chairman, there are 7 classes of anomaly. Class 1, segmental agenesis or hypoplasia. Class 2, unicornate uterus. Class 3, uterus didelphys. Class 4, bicornuate uterus. Class 5, septated uterus. Class 6, arcuate uterus. And class 7 is the diethyl cholesterol-related anomaly. First class is absence of uterus. We will not speak no uterus by ultrasound. Class 2, the unicornuate uterus is essentially have uterus didelphys with single hemiuterus divided to the right or the left midline, showing only single cornual angle. The diagnosis of unicornuate uterus is very difficult to confirm with 2D ultrasound because the findings are subtle. The nulliparous unicornuate uterus is somewhat smaller than normal and divided from midline to the multiplanar capability of 3D ultrasound permit confidential demonstration that there is only one corneal angle. As we see here in the picture, if we do looks like a normal uterus. If messed with normal uterus, here in corneal view, start to see a deviation or shortness. Here, by 3D ultrasound, we see it's a unicornate uterus. A multiplanar display of this unicornate uterus showed the diagnosis difficult to establish, as I said, with 2D ultrasound, because uterus may appear grossly normal, like here, or slightly deviated. With 3D ultrasound, the diagnosis confidentially made because the corneal plan shows clearly that only single horn is there. This picture will be again for it. The uterus didelphys consists of 2 distinguished separated uterocervical cavity. There is fundi and widely separated, maybe not be completely imaged on any single planar image. The cervix are adjacent to each other, but the cervical canal are distinguished. Like here, this is multiplanar 3D ultrasound for didelphys, composite of multi-display. You see here in A and C, a little bit more clear than B and D. The cervix from another volume is shown. The axial plan A show two widely separated hemiuteri, typical of this malformation. Sagittal plan here, in sagittal plan B, it's difficult to diagnose. There's 2 hemiuteri, therefore show very little. The coronal plan shows the widely separated fundal region arrow. The lower uterus segment and the cervical canal are closely opposite. Class 4 bicornuate uterus, which we have partial and complete bicornuate. has a mid-sagittal cleft or identification of external contour of the fundus at least 1 cm in the depth. And please concentrate about 1 cm in the depth. This is the difference between septated and bicornuate uterus. In the additional, the uterine cavity is divided by the septum that extend caudally for variable extent. The cervix and bicornuate uterus may be single or double. Like here. So maybe we have a 1 cervix or 2 cervix. Bicornuate uterus by 3D ultrasound. This coronal view shows deep less than 1 cm here. We have to measure this one, either by 3D or MRI. We have it's more than 1 cm midline sagittal groove here, which is characterized this type of uterine anomaly. In this case, a single cervix canal is shown, but there is in bicornuate we can find 2 cervical canals. Class 5, septated uterus. The most common uterine anomaly usually has a normal external fundal, and I think this is the most common cause of recurrent abortion if there is a uterine anomaly. Usually has normal external fundal contour, but may have shallow fundal indentation measured no more than 1 cm. And here, this is the difference between bicornuate and septate. Septated uterus, here by 3D ultrasound, multiplanar display, axial by A, it's difficult, sagittal, and coronal by C, and this is by 3D imaging, is very clear septated uterus. Subseptated uterus, 3-dimensional multiplanar sonohysterography. Sonohysterography shows a normal external uterine contour, and after that, when we do multiplanar, it's easy to diagnose subseptated uterus by this picture. Okay, class 6, arcuate uterus has a normal external fundal contour, but the inner fundal contour abnormality is which the fundal myometrium is convex toward the uterine lumen. This convex myometrium should not be exceed higher than 1 cm when measured from the corneal angle. The actual prevalence of arcuate uterus is unknown because the subtle abnormality is easily missed without visualization of the coronal plan. The clinical importance of this mild abnormality is uncertain, although this lesion is generally thought of as less problematic than septated uterus. This is the coronal view done by 3D ultrasound, can directly visualize endometrial fundal, and this is less than 1 cm also. Case 7, diastyle estroprestol related uterus has a hypoplastic cavity with variable deformity of the shape of the uterine cavity. The external uterine contour is normal, but the uterine cavity is smaller than normal and has been described as a T-shaped construction in the pulpus coronal region. And a deformed uterine body, lower uterine segment, may be widened, but more often show severe stenosis. Okay, this is T-shape. Fortunately, not more use this drug. Okay, here we saw some picture of endometrial polyp by 3D vaginal ultrasound. This is composite finding of subseptated uterus with multiple endometrial polyps. You see here, subseptated uterus and multiple polyps. Endometrial calcification with small submucous myoma also shows by 3D vaginal ultrasound. This is IUD, intrauterine contraceptive, coronal view obtained only with 3D ultrasound. IUD is shown be slightly caudal to the fundal myometrium, which convex toward the lumen in this subtated uterine anomaly. However, IUD is entirely with endometrial cavity without evidence of myometrial penetration. This is uterine synechia by hysterosonography and 3D vaginal ultrasound. This is synechia also, uterine synechia. Myometrium, uterine myomas can be assessed by 3D ultrasound. The multiplanar display, especially the coronal view, allow precise localization of myoma with respect to endometrial cavity. Persons localized of uterine myoma assist and determine the surgical approach, and which is very important. We have before surgery to determine our way to do the surgery for this. Approach hysteroscopy, resection, or abdominal myomectomy. This is hysterosonography also, intracavity myoma of endometrial polyp. Three-dimensional multiplanar sonohysterography shows round mass with azoechoic, with myometrium and almost completely surrounded by fluid. This is interactive myoma. I think it's easy to done by hysteroscopy. This is myoma by 3D vaginal ultrasound. This is cystic adenomyoma, composite of multiple display of the uterus. A coronal plan through the uterus is shown. There's a cystic mass in the right side. See here? Here. Cystic mass in the right side of the uterus containing uniform level echoes and surrounded by myometrium. My take-home message is, according to RCOG guideline, according to a lot of paper published in 3 past year, the golden standard diagnosis of uterine anomaly is 3D vaginal ultrasound. Then we can use hysterosonography accompanied by 3D ultrasound. MRI is a solution if there is a complicated anomaly. 2 or 3 together, we can use MRI to make a cut line that of diagnosis. Please make hysteroscopy and laparoscopy as approach of treatment, not of diagnosis. Thank you very much. I would thank Professor Saad for her support, and I hope that I complete this issue. Thank you.
Thank you, Dr. Umayma Abu Ghrara. Moving on to our next keynote speaker, Dr. Nadine Al-Sheikh. She has a bachelor's in medicine and surgery from the University of Az-Zawiya. She has a diploma in obstetrics and gynecology. She currently also teaches infertility diploma at the Arabic African University. Her topic will be talking about the prevalence of hypothyroidism and hypoprolactinemia in infertile women at Gadmoor Medical Center from 2017 to 2020. Could you give us a warm welcome, please?
السلام عليكم ورحمة الله وبركاته. مرحبا بضيوفنا الكرام. نحب نقدم لكم اليوم prevalence of hypothyroidism and hyperprolactinemia in subfertile women at Gadmoor Fertility Center. This presentation done by Fatma Al-Kilani, Ghada Ibrahim, Sumaya Al-Mur'ash, and me, Nadine Al-Sheikh, supervised by Dr. Yusuf Gadmoor. Subfertility can be caused by untreated thyroid disease. The prevalence of hypothyroidism is 2 to 4% in women at reproductive age group. Low thyroid hormone level lead to increased thyrotropin-releasing hormone, which stimulates pituitary gland to secrete thyroid-stimulating hormone and prolactin. Hypothyroidism can affect fertility due to hyperprolactinemia, anovulatory cycle, luteal phase defect, and sex hormone imbalance. What about prolactin test? For accurate prolactin test, the patient should be fasting 2 to 3 hours after wake up, not on during menstrual cycle, use of intravenous cannula, rest before taking sample up to 15 minutes. avoid intercourse the night before. This research to measure the prevalence of both hypothyroidism and hyperprolactinemia among subfertile women who attended Gedmore Fertility Center from 2017 to 2020. Method: study design retrospective case series study. Duration of study from 1 January 2017 to 31 December 2020. Site of study: Gedmore Fertility Center, Tripoli, Libya. Sampling medical chart of 503 subfertile women who visited the fertility clinic during the duration of the study were reviewed. Among of them, 108 cases of hypothyroidism and hyperprolactinemia were selected for the study. Out of 503 cases, the prevalence of hypothyroidism, hyperprolactinemia, and both are showed in table. 22 patients had hypothyroidism, 41 patients had hyperprolactinemia, and 45 patients had hypothyroidism with hyperprolactinemia. This graph shows distribution of hypothyroidism and hyperprolactinemia among participants. 20.4% had hypothyroidism. 38% had hyperprolactinemia. 41.6% had hypothyroidism and hyperprolactinemia. This table shows relation between hypothyroidism and hyperprolactinemia. Patient had hypothyroidism and hyperprolactinemia about 82.3%. And patient had hyperprolactinemia with no hypothyroidism, 47.7%. P-value about p-value 0.0. This table shows types of infertility among participants. Primary and secondary infertility. Primary infertility, 57 patients, 52.8%. Secondary infertility, 51 patients, 47.2%. This table shows duration of infertility among participants. Duration of infertility less than 4 years, 74 patients. From 5 to 8 years, 23 patients. From 9 to 12 years, 8 patients. More than 13 years, 4 patients. This table shows relation between duration and types of infertility among participants. Another causes of infertility. About 38.9% had male factor, 33% unexplained, 28.7% had uterine cause, 24% had anovulatory cause and BCO, 10% had endometriosis, 0.9% tubal cause. diagram shows fertility outcomes among participants. 20.4% had spontaneous pregnancy after treatment, and 78.7% not get pregnant, and 0.8% had ICSI and failed. Conclusion, hypothyroidism and hyperprolactinemia both are significantly associated together among subfertile women, 52.3%. So, measurement of TSH and prolactin should be done at early stage of subfertility. Treatment of hypothyroidism can be great benefit to conceive. 20.4% of our cases get pregnant after medical treatment. Thank you. نحب نشكر دكتورنا يوسف قدمور اللي يحرض فينا على العلم والتعلم ونحب نشكر كل دكتور علمنا سواء من ليبيا أو خارج ليبيا. كل الشكر لك.
Thank you, Dr. Nadine Al-Sheikh. This concludes our talks for this session. We will now move on to the discussion for this session. As per usual, if anybody has a question, they could please raise their hands. It will be governed by the panel.
Thank you to all presenters. Now we open the session for discussion. The first presenter was Prof. Abu Bakr al-Nashar. A person who has a question. Yes, please, doctor.
Dr. Nashar, I want to ask you something. You mentioned that niche lead to difficult embryo transfer. And I think if you don't exclude niche before you start ICSI trial, you shouldn't do ICSI trial.
Thank you. Can you please pass the microphone to Dr.
شكرا جزيلا. Thank you to everybody. Thank you, Noor Al-Hayat, for this nice chance to meet the expertise, our guests here. I want to ask about ovulation window or implantation window.
No, there is difference between implantation window and the fertile window.
Just a moment, because I want to ask about the ERA test. Are you doing there?
The ERA test is quite different. The ERA test is genetic one, depending on 137 genes and its value in what's called personalized embryo transfer, and according to the studies nowadays, of no value. It was issued or was by in Spain, and they propagated it all over the world, but according to, it was not documented to be beneficial in other studies.
Okay, just I want to ask another thing, please, excuse me, about genetic factors. I mean, you know, I want to say about one case I met last week. Yeah, she's 32 years old, and she had gone 2 trials of ICSI, and she had in these 2 trials 8 eggs M1, and the second trial was 24 in Egypt, 24 eggs with M1. I tried to do something different. For example, just extending. I'm not triggering on 17 or 18, between 18 and 20 millimeter follicles, and I'm trying to extend the delay the denudation of these follicles. Although of that, still she had this M1 oocytes, only 1 mature, and fertilization was abnormal. So, if anybody can help us in investigations and treatment of these patients.
Sorry.
Sorry, is it concluded?
Yeah, this is a question to our expertise here.
I can summarize what is raised by Dr. Naima, صح? About if we have a lot of M1 in spite of many oocytes, what we will do. In this condition, we can change the protocol, right? This is what, you changed the protocol. What's the protocol you used?
Before she used the antagonist protocols in the 2 previous cycles, so because of the shortage of antagonists in our country, we started progesterone primate protocol.
The simple one is better because there is an association between the protocol and also اعمل ايه بس انا قلت ان هي كده.
It is away from our system.
Yes, I quite agree with you, لكن انا ما اقدرش بان انا اقول لها لا. خلاص وهو احنا قلنا كده يبقى بنغير البروتوكول. وحاجه تانية كمان بالنسبه للتريجر ممكن بان احنا نغيره وحتى كمان نغير الايه.
Can I interfere? Can we pass the microphone to Prof.
Yeah,
Andros?
thank you.
I see he has a microphone.
Thank you. I need to ask some question to Professor Al-Nashar. Sorry, you're so busy with the microphone. Okay, so first of all, I was extremely surprised that you ignored coital frequency as an important factor in the coital window.
No,
so
we mentioned the frequency, and if you, it was in the slide at the bottom, with increased frequency at the time of fertile window, this will increase. In the past, there was a misconception, and the advice was to have sexual intercourse every 48 hours. It is not correct.
Agreed.
But it was found that if we have a frequent intercourse in poor semen, the second intercourse is associated with increased concentration and less abnormal forms.
Yes.
So if they can have more than one intercourse in the fertile period, this will increase the conception rate.
Yeah, we've actually shown
Yes,
that
I quite agree
4 hours
and
after the
this
first.
is also as this professor, what's called the split ejaculate.
Yes.
If the first ejaculate, and this happened, there was no sperm at all. And we give him 2 hours and he give us another specimen,
Yeah.
and there was sperm in the
Sorry, and then my second and last question is, or comment is that vitamin, I hope you're talking about vitamin D3, and that value of 80 nanograms, that's toxic, is total rubbish. If you measure the average value in farmers, short sleeves, it's under 250. It's not toxic in them. And I think it is a WHO value that has become old. And the ideal values now suggested is that we have between 60 and 80 D3. And in order to attain that, if you had 30, you need to start with 10,000 international units per day.
I understood to start on the day 2, not day 3. I didn't get your idea. About? Yes.
Yes. No, I'm saying if the... what I'm saying is, if the value is initially found to be 30 and treatment needs to start, it needs to start immediately with about 10,000 international units D3 per day for at least a month. And then you'll get it to 80 because it struggles to get from 30 to 80.
شكرا.
Thank you. Another question?
Okay. ثانية بعد إذن حضرتك. Thank you, Professor Nashar. And as we always expect from you, you add new dimensions to our knowledge. Thank you very much. According to the fertile window you have displayed to us, would you agree with me we could modify our practice in IUI instead of doing IUI after 36 hours of doing SCG, and you said that fertile period maximum is the day before ovulation. So could we modify our practice and do IUI?
There is a quite difference between.
Yes.
I got the point, and this is usually raised after this discussion. There is a quite difference between IUI and natural sexual intercourse. Quite difference. In the IUI, you are inseminating near the ovary, up in the uterus. But in the sexual intercourse, you are inseminating in the vagina. It will pass the cervix, right? Quite different. You cannot apply the rules, just a minute. You cannot apply the rules of the natural sexual intercourse with IUI.
Yes.
Thank you. Another question?
والحقيقه الفضل في اختيار الموضوع ده هو الدكتور المحيشي. انا كنت بعد مواضيع تانية بس هو اختار الموضوع ده.
Thanks, Professor Nashar. As regard to the fertility window, more than 25 years ago, in the Gulf area, Saudi Arabia, I was using IUI as a routine for unexplained infertility, and there is what is called biological watch. Yesterday with Professor Abdul Hafiz, one of the exhibition companies, saying that it will be available here within months, short months. So it is not يعني descriptive. It will be documented, but leave everything to nature. The most important item is the habit among Arabian female. After intercourse, immediately they go to the bathroom and washing. For infertile couple, sorry, you have to empty the bladder and stay in bed at least for 1 hour. The second most important is the caffeine. And the smoking طبعا must be prohibited. Alcohol not allowed at all in Islam. مش 2 cups per week as you said.
I quite agree, but we are addressing different religions, and we should mention that. لكن I quite agree, it should be prohibited for me.
To translate
Yes.
بقى ال overdose of caffeine to medium sized cups per day اللي هم equal لل 500 مللي جرام available. 2 بس مش واحدة. دي حاجة. السؤال بقى المهم, the first important question, did you advise empirical use of L-troxine for the infertile patient?
No.
Can I...
عفوا. قلت no.
Yeah.
I like your lecture because
Thank you. الله يخليك, انت اللي اخترتها.
Okay.
فالفضل يرجع ليك.
But I want to put a point. It might be, if you agree with me, for artificial insemination. So usually, they always, our patient calculate 36 hours. So I give the artificial insemination after the ECG, right?
Yes.
Then
How many
within
hours after
12 hours.
HCG?
Within 12 hours after the ECG, I'll do the artificial insemination.
Yes.
Don't wait. Then if you want to do intercourse after. And also, as you said, always I tell them, don't go for wash after intercourse, but go for after 15 minutes, go for a cup of coffee. Good Turkish Arabic coffee.
Good. According to the Cochrane systematic review regarding the timing between HCG and insemination, there is no difference between 12, 24, and even 48 hours.
I want to...
Right?
with all due apology to Dr.
Mohammed قايله كده, قايله ولا فرق ما بين 12 ولا 24 ولا 48.
We need to move to the second presenter, Dr. Umayma Gharara.
Just I want to ask about uterine niche. The
niche, yes.
Do you consider the laparoscopic way for the correction of niche?
Yes, we mentioned the recommended one.
Yes.
If the patient wants to get pregnant, is laparoscopy or vaginal.
Yes.
شكرا.
The second, how long the time given to the patient after the operation? I mean, 6 months.
6 months.
6 months.
دكتور أبو بكر من فضلك معلش سامحني. عادة نحن في البوليسي في our clinic combined clinic with endocrinologists regarding thyroid.
Very
we
good.
cannot, put our policy with them that we have to give thyroxine below. Usually we refer, they didn't usually start thyroxine.
No, I don't agree with you.
I want to ask you, this is our policy. We cannot start thyroxine, for example, for thyroid stimulation hormone 4.2 or 4. Usually we will refer, they will take time to work with or deal with the patient to confirm that she is exactly a case of hypothyroidism.
For my practice, I am treating the patient with hypothyroidism. And there is no need to refer her for endocrinologist. If the TSH is more than 4, I will start L-troxin. If it is more than 2.5 with thyroid peroxidase antibody is positive, I will start L-troxin. And my advice, don't refer her for endocrinologist. This is my practice. And you are doing the same?
Can we please shift to the second presenter, Dr. Umayma Bugharara? Is there somebody who has a question? To the second presenter whose lecture was on the role of 3D vaginal ultrasound in the diagnosis of uterine anomalies. Dr. Mohammed Boudabous, تفضل.
It was a very nice presentation, but the problem we are facing in Libya, lack of equipment. So I think the transvaginal three-dimension ultrasound, it's not variable for every clinic. So we have to refer the patient to maybe 1 or 2 centers around Libya. So we don't have the equipment. Yeah. This is the dilemma.
I just want to, I had a thought while the second presenter was presenting, and it's to pick on what Prof. Boudabous has said. I think in centers that does not have 3D, we should try to improve our skills in reaching the same diagnosis with the 2D.
Yes.
Yeah.
With with hysterosonography and 2D ultrasound, we will take 70% from 3D vaginal ultrasound. It's better than hysterosapengiogram, I think.
Thank you.
Yeah, can I just ask a point regarding 3D? She mentioned on the end of the talk, this is the golden standard by the Royal College guideline. I think this should be presented in the beginning of her speech. I haven't heard about that. What I am sure Nice mentioned that stated correctly. There is no rule for 3D as screening in gynae and obstetric. This is the real practice. Thank you.
Okay. Prof. Mohammed Al-Mhaishi.
أنا نبي ندير simplification يعني sorry for not for you but for our student. Try to control the vaginal ultrasound before the vaginal 4Ds. It is expensive and it's not a routine practice. So please, for gynecology routine practice, you have to learn how to get good diagnosis or pathology by normal vaginal ultrasound. If you learn this, 3 or 4D, you refer it once in a while.
Any more questions for the second presenter? Now we shift to the third presenter, Dr. Ghada Abdul Salam, and the topic was the prevalence of hypothyroidism and hyperprolactinemia in infertile women at Gadmore Medical Center. Yes, Prof.
Thanks, Dr. Ghada. Where is Dr. Ghada?
Sorry, it was given by Dr. Nadine.
She is out already, but there is a small
Is no Dr. Nadine present? She's present over there, okay.
هي الدكتورة عطتنا محاضرة الدكتورة يسرا.
أولا ألف سلامة على الكانيولا. الكانيولا دي من البريكوشن بتاع سحب العينة؟ طيب تمام، ألف سلامة. just small comment. Prolactin is a stressful hormone. لو حد ضايقني او في anxiety دي مشكله كبيره، بيرفع اوتوماتيك. ثانيا له diurnal variable within the 24 hour، له بيك في الصبح وبيك في الليل. even لو في bad dreams بيحصل شوتنج اوت. لو جينا نعمل ده في الكلينيكال ابلكيشن على الانفرتايل فيميل، غالبا most of them في ستريس، فالبرولاكتين بيبقى حتى even at the level of high normal مش within normal. وده السكرت في كل الريكوست اللي احنا بنطلبها، بيجي لك عالي وبتقعد تعالج برولاكتينيميا وما بتخفش. فعلشان كده في الناس دول التروكسين I think it is a practical point. الراجل ده كلنا سمعنا على البروفيسور ماهر مهران، ده Minister of Health in Egypt, lead professor and he was a pioneer. كان بيستخدم الالتروكسين empirical for all infertile women، وكانت الريزلتس بتبقى عاليه جدا depending على الستريس فاكتور. What is your opinion?
Prof, can I ask you to re-say that, repeat that in English, please? Because we have very solid physiologists here in the hall, and I would like them to comment on that.
Yes.
Yeah. So,
Stress is an important factor among infertile female.
Yes.
And this may increase prolactin.
Yes.
And the increased prolactin may denote subclinical hypothyroidism. Did you validate the empirical use of L-troxine among such patients?
Yeah, I think you are right. That's why the taking blood for serum prolactin should be with these conditions which we show to you. I mean, and this information I take it from andrology doctors, that you have to put cannula and then wait 10 minutes and then you take the blood. The lady, I asked her, don't do sexual intercourse the night before or the morning before, and she should be fasting, and she should not be over happy or over sad. All these may give you a wrong result. The second point, that I have to repeat any high prolactin, I will have repeated twice, and should be done in good lab and the same lab. And in that case, I will see if it is high. Maybe I will start with Dostanix, half a tablet, maybe twice per week, and then either increase the dose or decrease the dose. Concerning the thyroid, if the TSH is high and T3, T4 is normal, this is, we call it subclinical hypothyroidism. Also, you have to repeat it. Thyroid, I will use TSH only at the first visit. But if it is high, I will ask for T3, T4. If they are high, I will send it for endocrinology. If they are normal, I will not give treatment. Sometimes we give 25 milligram thyroxine. I don't know, I answer your question or not. Okay, thank you very much.
أنا بس I noticed that in your study, Yusuf, and your student, that 62%. It is too much, I think. Your percent, both of them, prolactin and the thyroid, TSH, you find abnormal in 62% of people, which is too high in your. Then also the other question, just very short, you didn't put the value or the number, which is abnormal, because of prolactin, if it is borderline or even 20, up to nearly 50% up than the normal. You have to beat and so, but it's not high, still not high. Just but when come and give the blood, I am shaking, prolactin goes up. And also, you didn't, I don't know why you said they have to be fasting in these 3 points. Thank you.
Dear audience, sorry, we exceeded our time in the session, so if there is 1 or 2 more questions and then we conclude, please. Yes, Doctor.
Yeah, Dr. Gadmour. In case of hyperproctemia, I think we shouldn't start, we will not put the hyperproctemia due to stress. And we have to exclude the pituitary gland. If we have to do MRI for pituitary gland, if it is microadenoma or macroadenoma, because you have to exclude that.
Oh yes, if it is.
You didn't mention that you checked the pituitary gland.
Of course. Well, if the second assessment is still high, and usually high means more than 30, 35, I will advise
35? If it is more than 100, it is mandatory to do MRI.
I ask the patient.
Although there is some conditions with microadenoma diagnosed below 100, but the recommendation, any patient with prolactin above 100, straightforward for MRI.
Even below that, I ask them, I advise them for MRI to exclude macroadenoma. I mean, I know that this is must be.
Thank you very much.
Concerning Dr. Al-Maheshi, this is our, I mean, statistic done with the second time we do prolactin. And the prolactin, the limit in my clinic, it is 20. If it is more than 20, it is abnormal.
Thank you to all the presenters. And we hereby conclude our session for today. And we move to another session. Thank you.
Okay, this concludes our second session for today. We'd like to invite you all to the coffee break. I would like to make a notice that the coffee break extends for 30 minutes. So if everybody can please make their seats in that time. Thank you. Enjoy.
My name is, sorry. My name is Professor Ralf Henkel. I'm coming from Reading in the United Kingdom, and I'm affiliated with Imperial College Department of Metabolism and Reproduction. My background is I'm an andrologist with biology and chemistry from what I studied. I am also been invited here to this conference, and I'm very much actually impressed what you people got up here. We are safe, we are very well looked after, and the conference is of high quality and international standard from a scientific point of view. Yeah, but this is what I said. I'm impressed. I feel safe. Feel looked well after.
Thank you
very
much.
much.
Thank you.
Thank you.
Hello, my name is Professor Gerhard van der Horst. I'm extremely privileged to be here as co-chairman of this amazing meeting. I come from Cape Town in South Africa. I'm a comparative spermatologist, studying all kinds of sperm, and I'm extremely privileged to be here in Libya. And not only privileged, it's an amazing experience. First of all, I must say the organization, the friendship, leave alone the food, and moreover, the fantastic lectures. I am impressed by the quality of papers that have been presented here, the order, how well everything is run. It is like one of the best international conferences I've attended, and I'm really impressed, and I'm very, very thankful for having this opportunity. I want to end off by saying that anybody that listens to this interview, and I hope it's a lot of people of interest, must not fear to come to Libya next year, hopefully for the same conference, and maybe we're doubling the number of people. It was a wonderful experience. Thank you.
Thank you. Thank you very much.
Thanks so much. Really, thank you so much.
Hello, I'm Dr. Liana Maria. I'm also from Cape Town in South Africa. Really a privilege to be here visiting you in Libya. Never thought that I'll be able to get to this country. What I enjoy most, or what I'm most impressed about the conference is the different topics that is being addressed. I mean, we're a mixture of andrologists, embryologists, clinicians, and we're all trying to work towards the same goal, and that is to help people with fertility problems. And I think the whole spectrum of this conference is dealing with that problem, and I hope we can contribute to this and this problem that might be not just over all in the world, but also here in Libya. Thank you.
Thank you for the opportunity to speak. My name is Dr. Sahar Abdul Rasul, and I am a senior lecturer at the University of Western Cape. I'm very pleased to be among you in Libya and to attend the first international conference of Nur al-Hayat, which is held for the period of the 5th to the 7th in Tripoli. And we were very much interested in all the presentations that have been presented in the conference, and we wish the conference conveners all the best, and we hope to meet you in the future. Thank you.
Testing, testing. Could our guests please take their places? Could I ask our guests to please take their places? We'll start with the session soon. Okay, continuing with our sessions, the next session will discuss the major theme of embryology. Without further ado, we now present the chairman of the session, Dr. Abdul Hakim Al-Nafati, Dr. Intisar Al-Musaytar, Professor Nazik Umar. Our first keynote speaker for this session will be Dr. Ahmed Nasser from Egypt. He's a senior clinical embryologist at Al-Medina IVF Labs in Alexandria and Cairo. He completed his Bachelor's of Science in Zoology and Chemistry at Alexandria University. He obtained his master's degree in clinical embryology from the School of Medicine at the University of Leeds. With almost 15 years of experience in ART and IVF labs, he currently is the Pre-Implantation Genetic Testing Program Director and trainer at Al-Medina IVF Labs. He's a co-founder of the Egyptian Society of Embryology and Assisted Reproductive Technology. His topic will be debating the ugly truth, embryology mechanism in pre-implantation genetic testing.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah. Dear guests, doctors, professors, first of all, let me thank the organizing committee for inviting me to give this talk or humble review. And it's really my honor to be here with you today, talking about this interesting topic for me, embryo mosaicism in PGT. So let me tell you a story, if you're all eager to hear a story, short one. I had a friend who's called Roger, and Roger is a regular guy working from 9 to 5, and he always dreamt about finding the perfect life partner to marry. And lately he met Jane, and they actually got married, and he was really happy with how she was smart, supporting, and beautiful and good looking, just like he wished for. And everything was going great until one night Jane went to sleep earlier than Roger. And then when Roger went to sleep, just before he fell asleep, he was shocked. He was shocked with this awkward sound. Jane was snoring. Actually, he was shocked. How could this be possible? His beautiful, pretty angel is snoring. Is that possible? Actually, he Googled snoring prevalence to find out that habitual snoring is prevalent in 44% in men and 28% in women. On the other hand, occasional snoring is universal. So someday, sooner or later, we are all going to snore. Leave this story aside a little bit. Yes. And let's go back to our topic. So it's well documented and believed that aneuploidies in embryos is responsible for a large ratio of pregnancy losses and infertility in general. It's also agreed that PGTA, doing trophoctoderm biopsy for blastocysts and doing NGS for this biopsy is the most trusted technique for diagnosis of aneuploidies. And this relies upon the concept that the biopsied cells are meant to be representing the whole embryo chromosomally. So, however, abnormalities can happen before the embryo is formed during meiosis or post-fertilization. And all the abnormalities that can happen post-fertilization can be responsible for the presence of chromosomally different cell lines in the same trophectoderm biopsy. And sensitive technologies such as NGS and array CGH can now differentiate between these cell lines and distinguish between the two types. The one is simple and uniform, which affects the whole embryo, against the other one, which is partial, affecting only some of the cells in the biopsy. So as you can see, this is an example for, the laser is not, this is an example for the different cell lines in this trophectoderm. As you can see, the red cells are the euploid cells, and there are some small number of yellow cells which are aneuploid. So this is not the natural way of happening. So this takes us to this code that NGS was able to detect the heterogeneity in the chromosomal content of the TE biopsied samples, revealing the ugly, shocking truth about the presence of chromosomally distinct or different cell lines in the same trophectoderm biopsy, meaning it's mosaic, regardless how the embryos looked beautiful and pretty on day 5 or the day of biopsy. So this, you can see here, this is what I was trying to link between the story I mentioned in the beginning and my talk. It's to accept the truth of the embryo mosaicism and do our homework to understand how mosaicism originates and how to deal with finding it in the diagnosis. So to speak about mosaicism today, we need to address some points. There's some slides that are not showing, surprisingly, but speaking about mosaicism, we need to address the types of mosaicism, the causes and events that lead to mosaicism, its prevalence, assessment and diagnosis, and how to manage patients after finding mosaicism in our diagnosing reports. So speaking about types of mosaicism, we have 3 types of mosaicism, and before speaking in details about these types, we need to see here that the first example is the one with a uniformly euploid embryo with no error at all, either before the formation of the embryo or after. And the second one is where meiotic errors occur, giving us abnormal gametes and thus giving us the outcome of an abnormal embryo, uniformly abnormal embryo with all the cells abnormal. However, the third type is the mitotic error, where it happens, the abnormality happens after the formation of the embryo, giving us one of these 3 types of mosaicism. The first one is the mosaic aneuploid, where various numbers of aneuploidies are present in the embryo or among the cells. The second one is euploid aneuploid, where there's a mix between normal euploid cells and abnormal aneuploid cells. And the third one is the most complex and the worst one, where more than 3 abnormal aneuploidies in addition to the euploid cells is present in the diagnosis. So, although understanding the etiology of mitotic errors during human embryo development remains complex, some cellular events were believed to be leading or causing embryo mosaicism. And one of these are non-disjunction during mitosis or anaphase lagging. And also there are other factors that might be affecting or causing, mosaicism. It might be clinical. Some believe it has to do something with clinical factors, just like clinical protocols or stimulations. The embryology lab could be affecting the outcome of the diagnosis for mosaicism. Maybe the culture conditions, fluctuations in temperatures and pH, the experience of the practitioner who's doing the biopsy technique itself, and the usage of laser. So moving to the rate of mosaicism, we have to differentiate between the prevalence and the degree. When talking about the prevalence of mosaicism, it's the frequency, or defined as the frequency of mosaic blastocysts within a certain cohort for a patient or more. However, the degree of mosaicism is the proportion of abnormal cells found in one blastocyst. So with advancing maternal age, embryos with aneuploid mosaicism are being more frequently diagnosed. Consequently, the prevalence of euploid embryos is reduced along with euploid, aneuploid mosaic. And a blastocyst diagnosed with chromosomal mosaicism following the report of PGTA can only be considered at risk of being mosaic, because simply it remains unachievable and very difficult to estimate the degree of mosaicism from a single biopsy. From the literature review, you can find that embryo mosaicism can range between 15 to 90% of occurrence level in cleavage embryos, comparing to 2 to 40% in blastocysts, and that's why the first step that has been that took place years ago, that all labs have shifted to day 5 embryo biopsy or blastocyst biopsy. However, as mentioned, that TE biopsy followed by NGS is the most commonly used method for PGTA. Studies have been done to assess the accuracy of this diagnostic technique by comparing the chromosomal content of multiple blastocyst portions, including the ICM itself, the inner cell mass. So before going through the results about these studies, this is the completely normal or the very happy scenario that we all hope for, that when you take the trophoctodermal biopsy and it's normal, the embryo is supposed to be completely normal and vice versa. However, discordance between the ICM and the TE, or the trophoctoderm, stemmed from a detection of structural abnormalities in either of the lineages. In example, for embryo number 1, you can find the trophoctoderm cells in green. They are completely normal, euploid, compared to the some monosomies have been found in the ICM. So this can give you a false negative diagnosis when being reported. On the other hand, embryo number 2, you can find the inner cell mass in green, which is completely normal, in comparison to some trisomies found in the trophoctoderm, which can give you a false positive diagnosis when receiving the report. So studies, this is the comparison of mosaicism rates across human blastocyst disaggregation studies. Several interesting studies, just like this one, done by Huang in 2017, where they analyzed 51 blastocysts that have been reported as abnormal blastocysts with array CGH, and they found 98% concordance between the ICM and the trophoctoderm. And they biopsied 4 portions from the trophoctoderm, 4 portions from the embryo. 3 of them were from the trophoctoderm and including 1 from the ICM. That's why they knew that there is a high concordance between the ICM cells and the TE cells diagnosed. Also, from all the 51 embryos diagnosed, they only found 1 embryo to give a false negative result, which is that the TE, trophoctoderm, was normal and the ICM was found to be abnormal. Another one done by Lawrence in 2019, they diagnosed 84 blastocysts and found a percentage of concordance of 93%. However, in this study, they found 3 blastocysts to give false positive results, and in addition to 3 others who gave false negative results. So obviously, these results will give us the conclusion that the number of biopsied cells and their location in the trophoctoderm will affect the rates of mosaicism reported. Also from these reviews, it's just suggested that mosaicism is largely associated with the possibility of misdiagnosis due to false positive errors whenever there's a high discordance between the inner cell mass and the trophoctoderm. And this gives rise to a question. So is diagnosing chromosomal mosaicism by PGTA a valuable thing to do for our patients during the IVF cycle? And this takes us to this really interesting study done by Richard Scott in 2012, which is presenting the most convincing evidence that PGTA is of a strong predictive value for the clinical outcome. And this study was, it's a blinded non-selection study where biopsied cells were kept and all the embryos were transferred not knowing the genetic diagnosis of these embryos. And just after receiving the clinical outcomes regarding pregnancy rate and live birth, the SNP array was done to these cells that have been biopsied before embryo transfer. And the results were really interesting. So 96% of the cells for the embryos that were diagnosed aneuploid, the embryos have failed to implant, compared to 41% of the cells that have been diagnosed as euploid for euploid embryos have led to ongoing pregnancies and even live birth. On the other hand, we will be kept in the middle with the other option, the euploid-aneuploid mosaicism, which remains remarkably complex. And this leaves you with one of the two scenarios. The first scenario is to take the conservative approach to put all the mosaic embryos in one category as not clinically suitable for embryo transfer. And this will consequently lead to a dramatic scenario for the patient where you can simply find no euploid embryos for transfer. Or this risk is also increasing with maternal age, and it will decrease the overall pregnancy probability for the patient. Or you can choose scenario 2, is to prevent the misclassification of euploid embryos as clinically unsuitable. How? By including a third category, which is the mosaic embryos. And this scenario can be supported by the evidence that we are already transferring mosaic embryos daily in our IVF routine cycles without knowing they are mosaic. And also, there is no clear evidence that there is an increased rate of chromosomal mosaicism in children born after ART. Consequently, you can say that mosaicism diagnosis will give the chance for us to save normal embryos from being discarded, yet it may lead to the transfer of abnormal embryos due to false negative results, for example, which will probably lead to implantation failure or miscarriage. However, this proportion or ratio is very, very low. False negative errors remains very low for as low as 4% and very rare to happen. So if you're interested in knowing what's really happening concerning the biological considerations about what really happens to the embryo and how could it be diagnosed as mosaic and end in a live, healthy baby, so a lot of hypotheses have been proclaimed, and they are still theoretical, and a lot of future studies are still in need to reveal the amazing insights of these potential mechanisms of self-correction for the embryos. Such like this study they done by Popovich, they extended the culture of the embryos outside the uterus, in vitro cultured, for 12 days post-fertilization. Okay. And they found 100% concordance for uniform unimerical aneuploidies, both in whole outgrowth and the ICM and TA-derived outgrowth portions. And for embryos diagnosed as mosaic, after the second biopsy, 12 days later, 71% of them were found to be euploid, with normal profiles observed in both ICM and trophoctoderm, which is a very high percentage of concordance. As we are increasing our knowledge about embryo mosaicism and studying how it is affected by other factors, patient management as well should be improved. So I encourage you all to check out the Pre-Implantation and Genetic Diagnosis International Society newsletters in 2019 and 2021, where they stated recommendations, practical recommendations that can come in handy to any clinician or a clinic for its patient's interests. And these recommendations were as follows. Concerning the patient management for the clinician, mosaicism rates and cutoff ranges should be reported in all the reports, and also stating what is the chromosomal abnormality to be found. Also, patients should be counseled that PGTA is not a 100% accurate technique yet. It's just like any other diagnostic test that can have its false positive or false negative results due to technical or biological issues. Also, patients should be counseled for the survival rates starting from the ICSI, moving by to the biopsy procedure, the mosaicism rate, the vitrification, and please do not generalize counseling forms or strategies. Just treat every patient and every case as unique. In 2019, the PGDIS released this diagram, which is very helpful in determining the cutoff ranges. In the middle, you can find the copy number, which is the euploid embryo, the line in the middle. This is the euploid embryo with 2 copy numbers of the chromosome. And as long as you go up to the trisomies, the risk increases until you reach trisomy, clear trisomy, and when you go down to monosomy, the risk also increases until you reach pure monosomy, and in between you can find mosaic embryos. Also in 2021, they released this figure to help clinicians and embryologists to decide what are their cutoff ranges in correlation to clinical outcomes like live birth, miscarriage, and implantation rates. So what we have to do now is to do 2 important things: classify, do the right classification for embryos, and prioritization. So when you do prioritization, first of all, the euploid embryos should be always your number 1 to go embryos to return. Then you can move to the mosaic low risk, either it's segmental or whole chromosome abnormalities, and then you can go all the way to mosaic high risk embryos. And whatever you do, please do not transfer aneuploid embryos, whatever happens. So whenever you decide or whenever you receive the diagnosis report that you have mosaic embryos, 100% of the embryos are mosaic, you need to counsel the patient. For the first choice is to initiate a further PGTA cycle to increase the chances of having euploid blastocysts or embryos in the second cycle. Or whenever the patient decides to transfer mosaic embryos, they need to understand that we will be giving the priority to the lower risk or lower level of mosaicism embryos first, and this should be done only after good counseling and professional counseling. Prenatal diagnosis and continuous follow-up is highly recommended for any pregnancy, especially after pregnancy is obtained with PGTA cycles. Maybe you can do NIPT at 9 weeks. And concerning the lab, the other recommendations for the lab are regarding the number of cells biopsied. It has to be monitored for minimum of 5 cells from the trophoctoderm to maximum of 10 cells maximum. The laser usage should be controlled, should be minimized to minimal shots, and the position of the laser shots should be in between the cell-cell junctions. Also, mosaicism rates in the lab should be always reported and monitored. If there is any shift in the mosaicism rate in the lab results or the practitioner results himself, this should be revised and troubleshooted. Lab reports should include mosaic embryos and the cutoff scores that been used to decide it. So to conclude this, from the transfer outcomes compared to euploid transfers, transfer of mosaic or mosaic segmental embryos do give rise to healthy pregnancies, but may be associated with reduced implantation and higher miscarriage rates. So in general, good success rates were achieved transferring mosaics with less than 40% mosaicism, whereas mosaics with 40 to 80% mosaicism were less likely to achieve a viable pregnancy. Including the percentage of mosaicism in our PGTA reports should be done carefully. And prenatal diagnosis follow-up of the established pregnancies by NIPT or amniocentesis revealed normal euploid fetuses, indicating that the story is different, and trophoctoderm mosaicism was most likely to be of a limited nature, and the embryo has gone through what's called self-correction. And all live births reported to date were healthy with no evidence of chromosome-based syndromes. So transfer of mosaic embryos appeared to be a relatively safe option, but only for couples with low or minimal risk of negative outcomes for the pregnancy. And this should be taking place only after expert advice and proper counseling of patients. So obviously the truth was not that ugly, and Roger has accepted the fact that his wife Jane is snoring. However, she could be the woman of his dreams, and he can have a beautiful family, and she can be the mother of his children. Okay, so these are the references for this talk today, and thank you very much. Sorry for keeping you long.
Thank you, Dr. Ahmed Nasser, for that amusing and informative presentation. That concludes our session for today, session 3. We'd like to move on to the discussion. If anybody has a question, as per usual, do raise their hand. The panel will be monitoring the discussion.
Presentation. Thank you, Dr. Ahmed, for this nice presentation. I like to start with my question. Is there any relation between abnormal chromosomal pattern and the age of IVF patient? Yes.
Why? Of course, yes. Studies have revealed that this risk increases with maternal age. Yes.
Yes. Why I said this question? Because more than 60% of our IVF patients above 40, and always I expect that they have abnormal chromosomes on our side. Thank you.
Yes, for sure.
Thank you, Dr. Ahmed, for a wonderful presentation. My question is, do you transfer low mosaic embryos in your clinic?
Do you transfer what?
Do you transfer low mosaic embryos?
Low mosaic?
Low mosaic.
Yes.
Yes. If the answer yes, you said yes.
But after expert and thorough counseling with the patient and signing the consent.
Okay. If these embryos are resulted with day 3 biopsy or day 5 biopsy?
Day 5. We only do day 5 biopsies.
Okay, day 5 biopsy, and you mentioned that the self-correction, how you give the gap to self-correct the embryos themselves.
How what?
How you give time to how you know that these embryos are self-corrected if you give time for self-correction?
We don't know, because it's still under studies and it's hypothetic. So we do not know what is the time frame of doing the self-correction. But as the study that has been done with in vitro culture of embryos up to 12 days post fertilization, 70% of the mosaic embryos were found to be euploid, normal euploid. So this is a very big percentage that give us the confidence to do so without knowing, of course. However, as you said, we transfer only low level or low risk mosaicism, and this also depends upon the cutoff level that the genetics lab give us and the level that you decide whenever you will do the transfer or not.
Okay, do you have criteria to transfer low mosaic in your lab? Like,
what do you mean by criteria?
If the patient has no option, the only embryos that resulted very low mosaic by the genetist's opinion.
We go through the report, and if we have several low level of mosaicism, we start to differentiate between which segmental and which is whole chromosome mosaicism, and we prefer the segmental ones because it has been proved that they have better clinical outcomes. And if they are all the same, we go to the morphological way, the old school, because they are all the same.
Transfer single or more
Maximum
than?
2.
Maximum 2. Yes. Because we do it in our lab, but maximum 1 with low mosaic by the recommendation of the genetics lab. But patient counsel is very important.
Exactly. We do counsel the patient for everything.
Yeah, but we
and
have zero
we recommend single embryo
transfer.
transfer.
Yes.
But sometimes that's
Okay,
why
thank
you get to
you
do.
very much.
You're welcome.
Thank you.
A nice talk, Dr. Ahmed.
Thank you.
Did you advocate biopsy for all, or there is a
No.
certain indication or high-risk groups?
No, as I said, you do not have to generalize. You have to treat each couple as a unique case.
The patient is coming for you, and just it is a history. Okay. What is the practical?
So what is the history?
Of the patient? Pregnancy is a recurrent implantation failure, delivery of mosaic baby.
Yes. We go for PGTA. Yes. Yes. But we do not do it for all.
Yes.
Okay.
Price in Egypt.
Welcome to Libya.
One more question. You said that one of the complications is laser.
Sorry, come again?
One of the complications, it could increase the mosaicism rate. The laser, using of laser. Do you do in your lab the flick out?
Yes, we do. We try to limit the laser shots for maximum 3 shots, and we do the flicking, and sometimes even if the embryo is in good shape and everything is going smoothly, we do not do the laser at all, and we do the flicking right away. However, we still need to increase our numbers in the data to know what is really doing the good job and not. Because personally, I feel that doing the flicking all the way from the first without using the laser might be also doing damage for the embryos and might give you a torn blastocyst, or you can lose some of the DNA, have DNA damage which cannot give you a robust DNA amplification when receiving the report for the NGS.
Okay, what about the maximum cells of trophectoderm has to
10.
be taken?
10 cells.
I think 10
this is too much.
Too much.
Yeah, but the PGDIS.
In our standard 3, maximum 5. If you have very nice trophectoderm, maximum 3.
I agree. It's
because
just,
you are harming the embryo.
Yes,
itself.
Exactly. It's just the PGIS
and the recovery rate will
newsletter.
be.
It's not for me, but for me, I agree with you completely.
Thank you very much.
Okay, so that concludes the discussion for the 3rd session. Moving on to the 4th session for today, which will discuss general topics. Without further ado, I'd like to present the chairmen of this session, Dr. Abu Ajala Akra, Professor Gerard Vanderhurst, and Dr. Liana Marie. Could you all join me to the stage, please? Our first keynote speaker for this session will be Professor Muhammad Salama from Egypt. He's a professor of obstetrics and gynecology from Manfiya University. He's also on the Fiqh Council of Mecca Al-Mukarramah. He's an Islamic organization for medical sciences. The topic will be legal rulings and medical developments in the field of infertility treatment. Could you give us a warm welcome, please?
First of all, I am very happy to be among all the attendees. And I am proud to نور الحياة. This is the first international conference, and actually it is well done. And there is 2 horses behind the door. Thanks a lot for them, Dr. Abdelaziz and Dr. Shalawih. Shukran. My topic today is a practical and ethical one. It is about the new medical issues and the merits of its legal ruling. فين حبيبي Yesterday, Professor Suad gave all the audience and the meeting maker flowers, but it was not arranged. Nowadays, she told me, please arrange the flower and give again for a second time. Thanks, Dr. Suad. طب قلب السهم ولا شكرا. باللغة العربية القضايا الطبية المستحدثة وحيثيات أحكامها الشرعية. To be a doctor, you have to be graduated, well trained, and to get a license, and to follow the regulation of the law. And on the same time, you have to upgrade your professional development and providing a high health service and to revalidate your license. There is the patient is the master and the physician is the servant. Actually, it is a right call in our practice. Why? Because there is a triple aim, acting in all countries, even USA. The doctor must give a better care for the individual, with a better health for the population, and on the same time, take care, not costing the health provider agencies. So, the doctors are under stress all the time for fear of medical error occurrence. And to prevent this, in short, we have to be aware and to notify about it, and the documentation is a must, and to analyze the data and put a strategy for each department, and put tools as a checklist for every procedure, and to apply in all the time, and to monitor and to re-evaluate the continuous improvement. In medical practice, the doctor have to stop what is the wrong way and what is the right and wrong way. Why? Because he is squeezed to act under legal, ethical, medical, and sometimes, la qaddar Allah, penalty. Professional ethics mean guidelines derived from the values and the principles that mean how to behave appropriately during the practice of various professional development. So, all over the countries, there are 4 pillars as regarding the medical ethics. Number one, patient autonomy. Then beneficence, then do no harm, and you have to be justice. 3 arms are added to the previous 4 pillars, that is to say, principles of confidentiality, protection of the vulnerable, and collegiality. We have to respect each other during the practice. The only beneficial from the difference, even with the talk with the patient, is the patient himself. So be aware. You have be care. You have to respect الزمالة. Religion plays a major role in people's attitude towards new medical developments in reproduction. Human response is largely shaped by religious belief. As we say, Muslims all over the world, Sunni Muslim 90% and Shia Muslim 10%. What is the difference? The difference, my relation with God in Sunnah is a direct one. No need to the presence of wasit. But in Shia, they consider themselves that they represent God authority. This is a belief. So there is a common medical issues will be cleared according to the Sunnah Islamic view. This is the topic. Number one, IVF. IVF, religious or not religious, simply it is permissible between spouses during their marital life to prevent the mix of lineage. ده يشترط 3 حاجات: وجود علاقة زوجية قائمة، ومفيش طرف ثالث، ووجود الاثنين على أحياء لمنع اختلاط الأنساب. ده خلاصة الموضوع. Second question: transfer of the fetus or the zygote after IVF in the womb of a hired woman other than the wife. What that is to say, surrogate mother, الأم المؤجرة أو الذئر باللغة العربية. هل يجوز إن بعد السكسس إن أنا أجيب أحط في رحم واحدة تانية؟ باختصار، الفقه كونسل in مكة approved it between harms and safety and regulation. ولكن legal choice there it is prohibited to mix lineage. هيجي سؤال تاني مهم جدا: who is the mother؟ اللي ادت الاوفا ولا اللي رعت في الرحم؟ who is the mother؟ اللي هي if pregnancy occurred, the owner of the egg or the owner of the uterus or both? The answer: the mother is the owner of the egg, and the owner of the uterus is the role of the mother from breastfeeding. يعني تنطبق من الرضاعة، تنطبق وكأنها أرضعت. This is in Islam. طيب، في مراكز أطفال الأنابيب بيبقى في redundant fetuses، ودولت هاي سورس فور ستيم سيل، اللي هي فوائد الأجنة. خلاص هي حملت، وحتى اللي مخزناه مش محتاجاه لأن خلاص اكتفت باللي جالها. طب فوائد الأجنة هنعدمها ولا هناخد منها الستيم سيل؟ It is forbidden to use it in the womb of another mother. طبعا خارج العلاقة الزوجية ده prohibited، ما فيهوش كلام. And it is permissible to execute it، ممكن نعدمها. And it is permissible to conduct scientific experiment on or without developing it. ممكن تجرى عليها الأبحاث وده كلام لوجيك، ده كلام فقهي مش كلام انا. الحاجه الثانيه this means it is forbidden to benefit it except in scientific research only. السؤال الثاني control of sex in the human fetus. generally في دول زي التشيك loving female fetus، وفي countries زي العرب والجلف اريا in general like the male fetus، ودي مشكله تحدث عنها الهولي قرآن. طيب هل يجوز بقى مع الادفانس في التكنولوجي ان احنا to control the sex؟ abortion as a method first of all is completely forbidden. يبقى الابورشن is not the way، ولكن separation of male sperm from the female sperm اللي هو الاكس والواي in the process of fertilization as desired، ده الطريقه اللي هتبقى متاحه. ازاي؟ ده موضوع كبير بنتكلم عنه بعدين. at the level ده الاساس المسموح. طيب هل يجوز نطبقه لكل المصريين او الليبيين؟ لا. at the level of the nation it is forbidden unanimously، ممنوع منع بات انه يطبق لكل الناس، مش بمزاج اجيب ولد او بنت، ولكن on individual level some see it is permissible. عنده بشرط ان يكون عنده 2 من نفس النوع، 2 فيميل او 2 ميل، وعاوز الاذر. some see it forbidden، الاراء الشرعيه واختلاف الفقهاء حكمه. some see it as forbidden at least it lead to a tyranny of one sex over the other. لو كلنا بنحب الصبيان، طب ده هيخلي فيه فجوه big distance between the number of available male and female، وده not liked. Transplantation of gonads and sex, that's to say egg donation, sperm donation, and embryo donation. In Islam, it is completely forbidden. Why? Because it is a sort of adultery. لو جبنا بويضة من حد خارجي أو سبرم من طرف ثالث بيعتبر حكمه في الإسلام زي حكم الزنا، ممنوع. طيب والجينيتال اورجان، واحده عندها مشكله في الفالف، واحده عنده مشكله في الميل بالذات في السايز اوف ذا بينس، هل ممكن يتعمل له حاجه زي دي؟ ليه؟ الانسر من الشريعه والفقه ان ده وسيله للترانسبورت and it is not a way for hereditary traits. جينيتيك انجينيرنج، طبعا كلنا عارفين جينيتيك انجينيرنج معناها انك تقط اند ترانسبورت اور تقط اند ريموف من الجينز. طب الكلام ده وده بيستخدم في الهيومن وبيستخدم في الانيمال والبلانت. It is permissible to genetically engineer human being، مسموح subject to control the diseases. في بيحكى ان في بعض الديزيزز بتبقى او معظمها كل في البيرسونلايزد ميديسين هتبقى لينكد لسيرتن كروموزوم، ممكن يشيل الكروموزوم to prevent the occurrence of the disease. طب في البلانت كلنا بناكل خضروات ولحوم فيها جينيتيك انجينيرنج، تلاقي حبه الفاكهه التفاحيه قد كده والاصليه حجمها العادي زي الاستفندية مثلا. ده تخيلوا ان ده مسموح بشرط انك تعرف الناس ان ده جينيتيكالي انجينيرد، يعني ما فيهوش خطا. ولو كان في طيه بروبابل ديزيز يبقى بريفنت. يعني الاسلام مع البينيفيت of the people. mapping of the human genome، كلنا بنسمع الخريطة الجينية. طب الكلام ده يعني انا ممكن اروح انا واولادي معايا فلوس وادفع واعرف الجينوم؟ The human genome is the mass of genetic material that includes complete map of human physical life and the diseases that he will suffer in the future. الكلام ده مسموح. The Human Genome Reading Project، في ده مشروع عالمي بدأ حتى أيام تطعيم الكورونا، كان في نوع في شريحة، وصدر بقى تخاريف إن دي دي معمولة علشان يراقبوا الناس. لا، Human Genome Reading Project is requirement for adequacy، يعني فرض كفاية. احنا عاوزين يشوفوا الانسيدنس بتاع حاجة معينة في ناس مصريين، بيروح على لوكاليتي وتكون عشوائية وياخد العدد اللي هو عاوزه، يبقى بيرميسبل للمصلحة because it is a valuable addition to the health and the medical science with legal control، بشرط ما يبقاش هبهزر. ما جيش انا الدكتور عبد الحفيظ والدكتوره سعاد عندهم مراكز وعاوزين يعملوا الاستادي دي يعملوها، لا، تبقى على الناشونال، على المستوى الدولة، ما تبقاش شخصية. genetic counseling in the family field، زي ما كنت بسأل الدكتور أحمد في الأنبلويدي والترايزومي، دي حاجات شائعة. طب والمصل ديستروفي وما شابه، طب هل أنا مسموح شرعا إن أنا أدور على أساس يمنع؟ تخيلوا جمال الإسلام بيقول إيه. genetic counseling is optional and generally not mandatory. القاعدة الأولانية ده حاجة معروضة ومش مندوبة. Number 2, it is desirable for those who are about to marry genetically guided. يعني لو في أسرة أنا هتجوز بنت عمي وبنت عمي المرض ده يعني ترانسميسبل في الأسرة، ممكن في الحالة دي نعمله. نمرة 3، is it advised not to marry relative، وده حديث نبوي، تباعدوا لا تضووا. كل ما تتجوز من بعيد كل ما يبقى النسل قوي. يبقى it is advised to marry not to marry relatives in families that complain of the emergence of a genetic disease and in some of their members. الفاكت نمبر 4، work to raise awareness of genetic disease، ولازم يتعمل public awareness للجينيتيك diseases. It is ABC. آخر حاجة، no person may be compelled to undergo a genetic test. أنا عاوز أجوز ابني من بنت أخويا وفي أسرة فيها، فما جيش أفرض على ابني إن أنا لازم أعمله، لا، بإرادته، not compulsed. ودي جمال الإسلام والشريعة. جينيتيك سيجنيتشر، البصمه الجينيه. الليجال تشويس، كلنا متاسف اي سبيك ان Arabic جاست فيو ووردز، سمعنا عن الممثل اللي كان مع واحده وحصل ولاده طفل وهو نكر نسبه، وكان دي ممثل مشهور في مصر او في الوطن العربي ككل، وحصل والمحكمه افضت بعد فتوى الازهر ان يعملوا الجينيتيك سيجنيتشر. طب امال العرب هنا حتى في ليبيا وفي السعوديه وفي بلاد الصحراء، في الصحراء بالذات، انا ممكن اقابلك ما شاء الله عليك انت ابن محمد تفعل، انا في دماغي ده اسمها الإيافة. الإيافة هي القدرة على افتراض ده ابن مين، وبعدين لو ما لقيتوش بقول له سبحان الله يخلق من الشبه 40. دي اسمها الإيافة، كانوا بيتعرفوا بيها العرب زمان، ده ابن مين وده يطلع لمين. طب دلوقتي الناس بينكروها، لازم في دليل مادي، فهنا مسموح. دي ان ايه فينجر برينتنج doesn't work in establishing lineage. ده اكسبت ان يعني ما يثبتش النسب الا في the event of conflict with the quality of evidence instead of إيافة، بدل الإيافة in Arabic يعني taking into account the safety control for the working with DNA. Transplant of stem cell into the brain. معروف ان الستيم سيل ترانسبلانتيشن في الوجينيك وفي اوتوجينيك. الاوتوجينيك ما فيهوش هزار، انا بياخدوا لي بلاد سامبل وبيعملوا لها سنترفيوجيشن وبيحضروا يا اما البي ار بي او ايزوليت الستيم سيل. اوتولوجاس ما فيهوش مشكله. لكن الالوجينيك متعلق بالجينز اللي هو المواد الوراثيه والحمل والولاده forbidden and not allowed. امال اهو forbidden to transfer stem cell from embryos into the womb of their mother. لكن الالوجينيك لو الستيم سيل دي بقى بريبيرد ان ذا لاب بنقول عليها induced mesenchymal stem cell allowed. يعني برضو الشريعه فيها مساحه للتفكير ومصلحه الناس. beginning of life، انتبهوا بقى بالذات البنات. أنا إمتى بنقول إن دي حياة يجب تحترم ويبقى القانون يعاقب عليها والإسلام محرمة؟ Human life لها 3 levels. Number 1 begin with fertilization and have respect. مجرد ما يحصل fertilization حتى في الاي في اف لاب قبل ما يتنقل يجب نحترمه. ده البيضة عندنا اللي راقد عليها الفرخة لا يجوز ان من تاني يوم وانا عارف ان لها لسه بيضة اسلقها واكلها. دي احترام. With the begin of it is magnified، الريسبكت ده magnified by breath of the soul، بنفخ الروح. ونفخ الروح العلماء اختلفوا فيه 40 يوم ولا 120 يوم على حسب المذاهب. ففي الحالة دي must be sanctified، يعني هنا respect، هنا تقدر، احترام وتقدير. وبمجرد ما يستهل الحياة بالكراينج خلاص له حقوقي وحقوقك وممنوع منع تام انك اهو.
Sorry, Professor. Your time is up. Can we give you another
yes,
two minutes? No, maximum 2 minutes, please.
Yes. Miscarriage in among the Muslim and the others, it is forbidden and not allowed. وبنشوف هنا العرب طب بيعملوا مظاهرات يقولوا لا، وبره في امريكا بيقولوا keep abortion legal. طب الاسلام بيقول ايه؟ aborting pregnancy before term is prohibited if it is after the soul، بعد نفخ الروح اتكلمنا عليه. ولكن permissible يعني مسموح به في الاكستريم ميديكال نيسيستي، لو في دواعي طبيه طفل فيه، وبرضه بشرط انك تتصرف قبل نفخ الروح. reduction of the fetus، الهاي اوردر بريجنانسي معروف انه كله كومبليكيشن. طب الريدكشن allowed منتهي. مينيمم اند ماكسيمم بريجنانسي ديوريشن، طالما في علاقه زوجيه 6 شهور 24 ويكس ده المينيمم ديوريشن فور بريجنانسي، والماكسيمم ما بتتعداش ال 44 ويكس. minimum and maximum pregnancy duration already finished. Surgical contraception. Passport on the individual scale، على المستوى الفردي ممكن اعملها for the safety of the mother، ولكن prohibited at the collective level على المستوى العام. Looking to the عورة for reasons of detection، أنا بتاع مسالك بشوف عورة الراجل السكس أورجان الإكسترنال، وفي الفيميل بتكتشف وشوف. It concern Muslims who are commanded not to look at the people private parts. Permissible with apparent limitation of the private parts what is needed أو diseased parts اللي هي تشاف بس. Sex change operation. السكس تشينج لو هتعمل ابجريد للدومينانت.
Sorry, with all respect to the audience and also the other speakers, can you please
Sorry,
round
I
up?
can consider me, I am finished. This is a highly valuable subject to the Muslim.
I understand, Professor. I'm not trying to be nasty. You have already spent more than 25 minutes. Why don't you show us your final conclusion slide, please? I've asked you to please present your final conclusion slide.
يعني رئيس جلسة الموضوع مش همه، تجيبوا واحد الموضوع يهمه. هايمنوغرافي. الهايمنوغرافي ريبير ده لو في سبيشال سيتويشن ماشي، ولكن لو دي زي البغاء اللي هي الادلتري ده نوت الاود، لان انت بيدخل في هنا يو ار ديسيفنج ا ثيرد بارتنر، انت بتغش طرف ثالث. Cesarean section in request not allowed only for obstetric and medical indication. Plastic surgery allowed. Less more than menstruation، دي حاجات للصلاة والصيام. أقل مدة نقطة وأكثرها 7 أيام. Less more berberium، أقل المدة اللي بينتهي فيها الدم وأكثره 6 أسابيع. Organ donation and sale. Organ donation permissible ولكن سيل بروهيبيتد. ميكس دي مهمه قوي، الميكس ميلك بانك علشان البري تيرم بيبيز هل الاود ولا نص الاود؟ جنرالي بيقول يو هاف تو نو ذا ماذرز. طب احنا بنحطه في تانكس هيبقى لمين؟ فقالوا ان ده بيبقى زي الام والام من الرضاعه، يعني الاود. خلاصه الموضوع البلانت والانيمال اند هيومن كلونينج in human not allowed, for research allowed in animal and plant. Job related secret طبعا we have to respect the secret of the patient and not tell the others even the relative إلا في some situation. خلاص. شكرا.
Thank you, Professor Muhammad Salama. Moving on with our session, our next keynote speaker is Dr. Ihab Abu Marar. I'm thankful the doctor actually made it today. He just arrived yesterday. Dr. Ihab has the Jordanian Board Certified Obstetric and Gynecology. He's also Arab Board Certified Obstetric and Gynecology. He has a German Facharzt of Obstetric and Gynecology. He's also an IVF subspecialty in Germany. He's an assistant professor of obstetrics and gynecology in the Yarmouk University, Jordan. He's a lecturer at the University Hospital of Schleswig-Holstein, Germany. He has published many research talks, books, chapters. He's a reviewer in many prestigious journals like the Journal of Assisted Reproduction and Genetics, now a senior consultant in ReproMed, Galloway, Ireland. Could you all give us a warm welcome, please? The doctor will talk about the cellar of poor responders.
Thank you, Mr. Chair. Thanks for the organizing committee, and thanks everyone for giving me the opportunity to present and meet such distinguished audience and speakers. So we're going to present the Center of Poor Responders, a place where any IVF specialist and embryologist, anybody who's involved in the fertility treatment would have been meeting, and it's a big dilemma that we all think about, so trying to solve it. So, starting with the introduction in order to understand where we can meet such cases, I will take the quote from Muasher, who mentioned that the definition of poor responders has differed widely in the literature and has included the woman's age, basal, hormonal status, and we're talking here specifically about the high FSH, previous cycle cancellation, and plus the poor response in a previous cycle with less than 3 to 4 oocytes retrieved, and plus or a peak of serum level of estrogen, which might be 500 to 900 picogram per ml. Now, moving forward with the introduction, We're having new screening techniques which are apparently appearing continuously, and due to that, it might be related to another hypothesis of understanding the poor responders and the poor ovarian reserve as well. So for the main other factors included, they added the basal antral follicle count, the AMH, which is the anti-Mullerian hormone everybody's aware of, cycle cancellation rate previously, and embryo yield, considering that the age is not anymore a main factor according to certain criteria in other places and experts. Now let's talk about the incidence and how frequent we can meet such cases. The poor responders in general incidence will vary dramatically depending on many factors. One of those factors is the population count, because we cannot include the population count when it's very little with the big countries as well. For sure the incidence is going to be different. Away from that, the IVF treated cases number, and that's why we see in certain centers representing certain incidence of 5%, while in other treating centers it might be approaching to maybe even 40%. Away from all that, the geographical region, like for example, with my experience working in the Middle East and Europe, these poor responders are more met in Europe because the trend is to treat for IVF in Europe, in general speaking, after the 35 years of age. So it's very normal to find women who are presenting for an IVF treatment at the age of 40 and 42, while in the Arab world, it's very unlikely to be met. Away from all that, the quality of ART services provided. People know that there's a well-known, well-structured IVF centers, so they can present themselves as a poor responders or old age, while, for example, when you refer a patient to a certain colleague in a country, they tell you it's well known to be very primitive. They don't offer advanced services. That's one of the other reasons of the variation of the incidence. Away from all that, the initial wide range extending would be 5 to 35%. To be honest, I saw and I read certain articles presenting that they might be presenting even more than 50% in certain places. So that's why I kept myself a bit conservative with presenting 5 to 35 of the ART treated cases in poor responders after pooling and talking in general. Now, why we are talking about this subject is of great importance to explain. So the importance of it is that all in all results of the poor ovarian reserve patients are reduced or inadequate folliculogenesis. We all that we're going to end up with a less desired number of oocytes to have our success rate accordingly. And that's because there's a defect during the folliculogenesis which is met in the poor responders in general, which leads to absence or reduced oocyte yield, bad oocyte quality. Yeah, sometimes you might end up with having, for example, 10 oocytes of which only one of them is fertilized. After that, the decreased or absence of fertilization and its rate as well. After that, the improper or failure to divide. Some or many of the embryos of the poor responders will face an arrest to a certain stage, and that's why we call it failure to divide. And then after that, failure to expand or blastulate as well. They might arrest at the level of day 3, day 4, or maybe even day 2. Higher incidence of cycle cancellation, which is very frustrating to both the caregiver and the patient herself or the couple. Lower success rate of pregnancy, whether it could be clinical or ongoing other than the cumulative. Increased IVF attempts number. For sure, we all know after experiencing the failure to fertilize or failure to divide, the patient is willing to repeat again. So that's why the cancellation rate is very high other than the IVF attempts. Multiple unsuccessful treatment cycle. We all faced these unfortunate patients who are coming and saying that I did IVF cycles 5, 7. I met persons with 22 trials of IVF. And higher cost. And regards to higher cost, There was a nice story. I met a patient in Saudi Arabia who did, as I told you, more than 20 trials of IVF. And while she was explaining everything, her husband was sitting and he asked me, what is the cost of establishing an IVF center? And when I asked him why, he said, because I already paid more than that. If I would have been knowing that I'm going to undergo a 22 IVF trials with no kid, I would have been building and making my own IVF center from the beginning because I heard that it makes money. Anyway, so moving forward, other than the higher cost, there is a heavier psychological burden on patient and caregiver. The patient feels ashamed, very frustrated, and the caregiver as well, because failure of having division, for example, or at least one blastocyst to a certain stage is very frustrating to the embryologist and the doctor as well. So that's another important thing to talk about. Now, talking about poor responder will lead us directly to the poor ovarian reserve to talk about and to understand. And this was addressed by many consensus. One of them is Bologna criteria, which mentioned the poor ovarian reserve as being the advanced maternal age, which is more than 40, or any other risk factors for poor ovarian reserve, like, for example, pelvic operations and so on. The previous poor ovarian reserve, which is less than or equal to 3 oocytes with a conventional stimulation protocol, and keep in mind that it should be a conventional one. And then the third one is the abnormal ovarian reserve test, which is having antral follicle count somewhere between 5 and 7, and follicles or AMH of between 5 and 1.5 nanogram per ml. So two of these three, if could be met, we can consider her as being a poor ovarian reserve patient. Now, other than the Bologna criteria, we have the Poseidon consensus again after that, which faced the difficulties in diagnosing the patient. And they mentioned another criteria which consists of 4 groups. Group 1 having an age of less than 35, antral follicle count of 5 or more, AMH equal or more of 1.2. And this will lead us to the subgroup of 1A, which is having less than 4 antral follicle count, and another subgroup which is 1B with an antral follicle count between 4 and 9. Group 2 is having an age of more than 35. So what I wanted to tell is that poor responders is not obligatory always to be met after the 40 years of age. We face them in less than 35 age sometimes, and that's why Poseidon criteria was developed. So for those of group 2, the age is more than 35, antral follicle count of more than 5, AMH of more than or equal to 1.2, and they have another 2 subgroups, A and B, which they are referring to the antral follicle count, again, less than 4 or somewhere between 4 and 9. Oh, it's going back. Sorry. So this is the Poseidon criteria group 3 and 4. Group 3 of less than 35 years of all, antral follicle count of less than 5, and AMH of less than 1.2, and group 4 of more than 35 years of age, less than 5 antral follicle count, and AMH of less than 1.2. Now, the physiology for these people of poor ovarian reserve is that woman germ cells pooling in the gonads experiences a decline for each and every woman in general after the age of 30. Now, the follicular consumption may be accelerated or decelerated due to certain known or unknown factors. One of them we could have been mentioning, the phase of having the chemotherapy treatment, radiology treatment, the strenuous exercise, or daily habits. Now, away from all that, the age, ovulation, and follicular atresia, which all women are experiencing on a monthly basis, are of the factors inversely affecting the ovarian reserve as a normal physiological mechanism This is how nature is, and we cannot stop that from happening. Some people would say and believe that taking oral contraceptives for a period of time might be stopping that mechanism, but it's proved not to be. Now, the pathophysiology for these cases, the addressed ones are many, like endometrioma, infection, ovarian surgery, TB, tuberculosis, and uterine artery embolization. After that, chemotherapy, radiotherapy, obesity, smoking, ethnicity itself, because they found that during some studies, while they experienced in certain ethnic groups, in general, ovarian reserve is higher or poorer, depending on the ethnicity. Gene expression and FSH receptors polymorphism, as we all know, strenuous exercise, sleep quality itself, pollutants, alcohol consumption, pesticides, stress and menarche, and finally environmental and lifestyle habits, like, for example, the food type, whether it's a junk one or not, and then the fluid intake. Now this will take us to the treatment. Many modalities of treatment were addressed for the poor responders, of which they applied the high doses, but not the very high doses of gonadotropins. Away from that, could be through long protocol, antagonist protocol, flare protocol with or without the oral contraceptives. Away from that, the double stimulation, eggs accumulation, embryo pooling, and mini IVF. Variability of outcomes after each protocol leads to no certain protocol superiority over the others. If you go through the experts, and there are many in this room, and you ask them, how would you deal with the poor responders, each and every one will give you a certain answer, according to their experience, anecdotal reports, their readings, researches, and so. So that's why the treatments are variable, but we're trying to figure out what could be more helpful in treating these cases. Now, I will talk specifically about dual stem, because this is a big area to discuss, and maybe this approach is a novel one and the newest technique in order to treat the poor responders. So the dual stimulation protocol idea was raised and applied after proving the assumption of 2 or maybe 3 waves of follicular development in one menstrual cycle. We all know that the follicular development, when we were studying in the 2000s and so, that it's during the follicular phase of the cycle. Well, this is abandoned. It's not valid anymore. I'm not talking about guidelines. There are no guidelines in this regard, but after certain researches, they found that there is a follicular development ongoing in the luteal phase, and we will prove that in the coming slides. So according to Sankara, he said that the applied protocol had a big advantage after the finding that any extra, even 1 egg, would make a difference in live birth rate in poor ovarian reserve IVF-treated patients. And that's according to the statistics done after treating these cases. There's a preparation for the dual stem in order to increase the chances of the success rate after such a treatment. And this would include maybe, to people who applied this, is the dihydroepiandrosterone sulfate, actually. It's dihydroepiandrosterone sulfate. And it's a steroid prohormone originating from ovarian theca cells and the adrenal cortex, and it's an androgenic supplement given to improve the number of oocytes collected in poor ovarian reserve. To be honest, this treatment was given, and it does increase the number of the collected eggs at the egg retrieval, but there are debate and very questionable about their quality. Addition of empirical treatment in general, the supplements of the empirical treatment like growth hormone, transdermal testosterone, L-arginine, and pyridostigmine are still experimental treatment trials that have not been shown to improve IVF cycles and outcome in poor ovarian reserve. But I would suggest, and I would recommend doing a hyphosi for these patients. Yesterday we were talking about this. Why do I need to make a hyphosi for a patient who's undergoing an ICSI? Because these patients are very high candidate to cancellation and switching from IGSI to IUI. Many of us would have been having a patient with a low AMH, and you start with the highest dose that you can, aiming to have 7 or 5 follicles, and you end up with 1. In these cases, it's not worth it to do an IGSI for only 1 egg, so it's better to switch it to an IUI. When you do high FOSI before starting the treatment, you're at least dealing with the flush tubes, which are patent, and it's worth it to go for the IUI or the time sexual intercourse instead of going for an IGSI for only 1 egg with a very questionable quality, might end up with no division. Now, this is how we do the dual stem. There are many ways that you can apply the dual stem, but I chose this one, but it's open for discussion as well. So day 1 or 2 or 3, we start stimulation. Day 6 or 7, we apply the antagonist. After that, triggering when 1 or more follicle of size of 17 millimeters, we do egg collection, and then we apply the IVF or ICSI treatment. After that, we freeze. After this, in day 1 or day 3 or day 5, sometimes we do ultrasonography, or we might go even blindly. We start again luteal phase stimulation, and we apply the antagonist immediately for the patient not to bleed and to keep antagonized. When we're having, again, 1 egg or more of 17 millimeters, we trigger, we do egg collection, applying IVF or ICSI, and then we freeze again. So there is no fresh transfer of any embryos during the dual stem. Now, according to Lou, a study which was done in the 2020, a review done retrospectively through the medical records of 304 women which were diagnosed as poor ovarian reserve and treated with dual stem. The numbers of oocyte collected, fertilized oocyte, divided embryos, frozen embryos, and good quality ones, other than the blastulation rate of luteal phase support stage, found significantly higher than the follicular phase support. You will be shocked with this info, but this is exactly what happens, and this is exactly what we are facing on a daily basis. It's always higher number of luteal phase oocytes that we get, higher than the follicular one. So the advantages of, I'm trying to run to make myself on time. So the dual stem advantages are the higher number of oocytes and embryo per cycle, chromosomally higher number of normal blastocysts after doing PGTA or screening, better numbers of luteal phase support oocytes in comparison to the follicular one, reducing time to gain 1 normal embryo in 1 cycle, more convenient to patients than the multi-stem in more than 1 cycle, and finally, it reduces the dropout rate, which is very important to us. The disadvantage of dual stem, cancellation in the luteal phase. Sometimes you don't have any eggs to stimulate. Sometimes there are no follicles. Suitable only for the poor responders patients. You cannot apply this, for example, for a high response patients. And then after that, only freeze all is applied because there's no fresh transfer. Higher cost in certain centers. You apply maybe, you pay maybe double. Others are less. Increased of total dosage of gonadotropins, and it needs more studies ongoing. Yeah.
Time is up, please.
That's it. This is Galway, the place where I live and work. I just wanted to share this with you. And Professor Hinkle, we were talking about that yesterday. It's far west of the west of Ireland. Thank you very much.
Thank you, Dr. Ihab. Moving on to our first and final oral presentation for today's session, could I call upon to the stage Dr. Amal Al-Haj. She's a specialist in obstetrics and gynecology and infertility. She also holds a master's in infertility. She'll be talking about the impact of women's age and pregnancy success rates.
Assalamu alaikum. I am deeply honored and happy to have our meeting here. It's an honor to have opportunity to see all of us. So today I am going to talk about the impact of women age and the pregnancy success rate on the 3rd day versus 5th day following intracytoplasmic sperm injection. Okay, how we can do? It's not working? Hello? Still not working? Oh, this is a problem of technology. Yeah, okay. It's now okay. This presentation is divided into 5 sections. Each section will take a deep look on the significance and implication of the finding from this study. I try to press. Sorry, this is a technical problem. Infertility is a subject that oftentimes shied away from due to the culture taboos, when in reality is a common health issue affecting as 186 million people worldwide. Infertility is a condition that has a profound socio-cultural, economic, and health implication in the individual and the society they live in within. In actuality, the couple experiences in their fertility undergo insurmountable personal grief, devastation, and social stigmatism like polygamy and divorce, and financial challenge as a result of the cost of the assisted reproductive technology. Okay, it's working? The aim of this study was to develop to a clear understanding of the impact of women's age and the pregnancy success rate on the 3rd day cleavage stage versus 5th day blastocyte stage following intracytoplasmic sperm injection. It was necessary to determine the implication of the extent the embryo transfer across the age group, to observe all these changes across this age group, and to determine which result is the best outcome. This study, conducted in Specialty Center of the Infertility and Genetic Tribunal Libya, it's a prospective randomized study of 1,184 couples in the private center. In this section, I will be focusing on the depth of the literature that has already produced on the topic of the day of embryo transfer by dividing them in 3 groups. Pro-cleavage stage, the second group for the people who are in favorable blastocyte embryo transfer, the 3rd group who are no difference, and they're finding no significant difference across the other group. Neuhauser 2020 claims that the choice of cleavage stage is still beneficial and the patient who are poor respond, poor embryo development, and decrease the number of the embryo. With the researchers such as Grander 2044 spearheading conversation of transfer of the single blastocyte comparison with the two blastocytes and increase the pregnancy rate and increase the implantation rate. Glochovsky 2016 said that the transfer of the blastocyte result increased implantation rate and pregnancy rate and also increase the success rate. Papinocula 2006, there is a clear evidence demonstrated that the transfer of the blastocyte lead to decrease the risk of the early stage miscarriage. The other study, Martin 2017, showed there is no significant difference based on though there is no benefit of blastocyte over cleavage stage in increase the live birth and ongoing pregnancy. A Turkish study was done in 2017. There is no significant difference rather than inadequacy of the third stage in the term of predictability stirs the clinician to delay the embryo transfer. The material method, I will provide a quick overview in the steps that were conducted. First, this is a prospective randomized study with the 1,184 couples that are ethically approved, and in which this study divided across the 3 age group according to 20 and 30 and 40, and each group were subdivided into 2 groups according to the day of embryo transfer. I'll provide you attention to the image posted on the screen. This image explains the exit process from the patient selection, education, and the counseling. And once everything is going on and the patient will be ready for the exit, there is various pituitary downregulation protocol, either agonist and agonist. The choice of each protocols dependent on the benefit of the patient and the limitation. We are following the ISHRI guideline 2019. Once the ovarian stimulation began with the gonadotrophin, with oocyte collection start. So the dose of the gonadotrophin will depend on the patient age and according to the body mass index and according to the response of previous polycystic ovary. Okay, so I will not take time this one. All of us you know how this is a procedure will be done. From oocyte collection and from the sperm preparation, from the exit process, once that the culturing and the embryo transferring under abdominal ultrasound. Once everything is done, the pregnancy test will check it, and fetal transvaginal ultrasound will confirm the clinical pregnancy at 5 weeks. Okay, sorry. Before the synthesis of the result before the synthesis of the result, I will mention the type of statistical that we have mentioned. We have statistical package of the social science version 2025 and Pearson chi-square to determine if there is significance between the 2 groups. In this graph, it's a breakdown of the population, which 1,184, by dividing them into groups according to the day of embryo transfer. Here we can say, as the age is the most focus on this study, we can say that the 40 age group, patients within 40 age group, 40 and 49, are the highest age group, 444, means 37.5. The smallest age group was in the youngest age group, 27.7. Meanwhile, the middle age groups, 34.8. More than ever, the women over 40 makes up the most rapidly rising group worldwide, according to Glochovsky 2016. This graph exhibits the attempt of the exit cycle from no previous attempt, 70.85, to all the way to the more than 4 attempt, 2.28. The failure of the attempt, it's not sustained to discontinue the failure, but we have to, it's not a predictor to continue the failed attempt. So there is success from every attempt. This is from the Cameron 2020. It's not a predictor to the continued failed attempt. This graph shows the patient distribution of the patient according to the age group on the day 3 and the day 5. As we can, they're relatively similar. This is the table for the breakdown of the parameter according to the age group, as the means calculated by the means plus and minus standard deviation. This graph, the number of oocytes according to the age group, as divided into the number of the participant who has more than was 1 and 4 oocytes, and which you see it by the dark brown color, and the number of the participant who has more than 4 oocytes. As you can see, the highest age group was in the 20 and the 30. Meanwhile, the lowest age group, the oldest age group has more, but it's 1 and 4 oocytes. Means that indicate of the poor ovarian response according to according to the Isher standard 2019. Physiologically speaking, it's normal and understandable as increase the women age, decrease the reproductive potential, and decrease the oocyte, and decrease the oocyte, and decrease the quality and the quantity of us. Emil Vermans, 2016. Here we can graph the number of the fertilized oocytes according to the age group. As we can see that the highest number of the fertilized oocytes was in the 30 and the 20, compared to the oldest age have less than 1 to 4 oocyte fertilizer. This is according to the study published in journal titled Seminar Palermo and her colleague, that in spite of the assisted reproductive technology, during which sperm injected directly into the mature oocyte, the failure of oocyte fertilization is still occur due to the activation of oocyte, that one of the causes of the failure of the fertilization. This is the pregnancy status according to the, as we can see, with 48.3 has not achieved the clinical pregnancy, and 600, about 50.7 were able to have positive human chorionic gonadotrophin, and also we have visible fetal echo under ultrasound at 5 weeks to confirm that there is a clinical pregnancy. Out of 600, 527, 88% continue clinical pregnancy. Meanwhile, 33 about 8.8 that has first trimester miscarriage. The one of the common causes that of unpromoted miscarriage in the first trimester is due to the chromosomal abnormality. 20 patients have about 3.3 have second trimester miscarriage. Out of 1,184, we have about 44.5 for 527 complete the delivery and achieve the pregnancy and go home with babies or with baby and their babies. About 55.5 not achieve the delivery all the way to the delivery. This is the clinical pregnancy state according to the day of embryo transfer. As we can see, there is highly statistical significance between the day of embryo transfer and there is a clinical pregnancy rate according to the day of embryo transfer. Promoted by high achievement in the 5-day in comparison to the 58% in the 5-day in comparison with the 42.8 in the 3rd day. Meanwhile, 49.3 unable to achieve the whether day 3 or day 5 unable to achieve the clinical pregnancy. This is a clinical pregnancy according to the day 3, according to the age group. According to the age group, the number of the participants of the clinical pregnancy according to the age group, the highest achieved during 20 and 30 in comparison to 28.3 in the oldest group, they are not achieved. The clinical pregnancy status of the embryo according to the day 5 of embryo transfer. As we can see that the highest pregnancy rate was in the 30 and the 40 and 30 and the 20 years of age. This 75.5 in the 20 years of age and 69% in the 30 years of age. In comparison to the 3.3.3, they are no, there is no, in comparison, there is little the percentage. The highest failure rate was seen in the oldest age group, 66.7. The delivery stage based on the age, as you can see, highest in the youngest age group in comparison to the oldest group. This is delivery state based on the day of embryo transfer. As we can see, the 54.5 promoted high achievement on the clinical on the delivery in comparison to those patients who have 34% who are in the day 3. This is and this is all of all of these slides are statistically significant between the embryo transfer and the day of between the day of embryo transfer and the patient that achieves the delivery. The day of embryo transfer and the delivery outcome, this greatly emphasized that the patient who was in the day 3 and the day 5, sorry, produced more multiple pregnancy. As we can see, 43.1 twins and 6.3 triplet. Conclusion and conclusion. This study successfully determined that the female age is a pivotal component affecting that infertility, greatly emphasized the benefit of the delayed embryo transfer at the 5-day in comparison to day 3 in the patient who are oldest age more than 40. This study successfully proved the female age is a contributing factor, especially the transfer of the blastocyte produces the greater success in the term of pregnancy rate, implantation rate, and the delivery rate. Further recommendation of the using of the single blastocyte instead of the 2 or more blastocyte or to reduce the incidence of multiple pregnancy. Make the smaller age category. For example, instead of we make it to 20 to 29, we make it 20 to 25. So especially in the older age group and the 30 age group. So we can more focusing in each case and each age in detail and to get the big result. Thank you for listening.
Thank you, Dr. Amal, and that brings us to the end of our talks for this session. We'll now move on to the discussion. As per usual, if anybody has a question, could they please raise their hands? The panel will be moderating the discussion.
Mohammed, yes, please.
Okay, the last, I think, not the least, we're almost finishing, but I want to actually first to thank Dr. Muhammad for his nice, difficult, long time to prepare his legal, and he has to translate, and so took about a week for him, and we changed. Thank you, and it was very good lecture, and it is available there. Everybody can take it from the organizing committee, because it is important, and you should everybody read it, because it can cover everything. How to protect yourself from the court, and how you protect yourself from the God. So it is very critical, and maybe need more time, but many thanks to Dr. Muhammad for the lecture. Mind you, I put the pressure on him to do it. He doesn't want to do it. But I know he can do it, and he done it in perfect way. I was actually in representative for Libya in the baby or embryo, and made and I can't even translate it there, which is in the office there in Bahrain legal, and it was in Azhar, and what he said to you, almost exactly the decision we restored. And one point there was in our meeting, the Iranian people, we asked them, they said, we allowed to take sperm from the bank, and the mullah told us so. So myself and Professor Jamal Abu Surur and somebody else, can't remember the names, we kicked them out actually. And you have no place in deciding in our religion. So thank you again for you. Just to finish, by the way, if not because together we don't take time, Dr. Amal, to be honest, it is not making very clear what you want from the lecture. So you should give us a total all pregnancy rate and ages, and so, but only one point. I got it from you that to transfer any blastocyst this is your advice. But also the percent you put it for pregnancy, that's super. I don't think you can get it. It is 47 or something like this, with even a pregnancy or baby taken home. I doubted in that. I don't know. It is very difficult. Don't listen to who said my progress rate 60, 70, maybe selected, no need to do an exit. Yeah. But all over the world, still under 40.
Thank
35,
you. Yeah.
34, 36. This is the percent for taken baby home. And thank you.
Yeah. Thank you for your questions. I would like to say,
Yes.
Sorry. I would like to mention something, that when starting this study, first of all, we to choose for a lot of patients, finally included this 101,084 patients to be included in study, to be eligible after the exclusion criteria. So many patients which are not satisfied with other study, so remove it. That's why the pregnancy rate is high. This is for the reason. And this is actually impact what's the blastocyte effect in the result.
ألف شكر دكتور محمد بيه على المحاضرة الجميلة جدا. فعلا الموضوع ده يهمنا كلنا الحمد لله كبراكتس. أنا طبعا عاوز أستغل بس فرصة وجود حضرتك، وحضرتك قلت لنا دلوقتي على قصة اليوتراين سيرجوسي. لغاية الآن دار الإفتاء المصرية وهيئة كبار العلماء ما طلعوش فتوى فيها، فهم القصة عندهم إن هم بيبقوا محتاجين يتقدم لهم طلب أو مشروع، بيجي يقعد لجنة من المتخصصين الأطباء يشرحهم للجنة هم بيعملوا إيه، وبناء عليه بيطلع فتوى زي ما طلع الفتوى في قصة اختيار نوع الجنين. قعدوا حضراتكم قعدتوا معاهم طلعوا فتوى قالوا انها مسموح بها على مستوى الاسره ولا غير مسموح بها على مستوى المجتمع. فبالنسبه لموضوع اليوتراين سيرجسي حضرتك قلت دلوقتي لا ده ما فيش مشكله لان اليوترس ده مش هيدي لنا جينز او كده. لغايه الان احنا ما نقدرش طبعا كممارسين نمارس الموضوع ده الى ان يطلع لنا فتوى، لان طبعا انا بس عاوز اقول برضو للشباب الاطباء ان انا رقم واحد ملتزم بالقانون بتاع الدوله بيقول ايه الاول، فما اقدرش اعمل عمليه او اي بروسيجر الا لما القانون يكون بيبيحها، يا اما جو تو جيل. بعد كده بنشوف الدين هيقول ايه. فطبعا انا ببقى حظي جميل لو القانون والدين الاثنين بيدوني نفس الايه الحاجه. فانا استاذن حضرتك ونستغل طبعا عمل حضرتك النقابي الجميل ان حضرتك تتقدم بطلب للقعده مع مع هيئه كبار العلماء بحيث ان يطلع لنا فتاوي في المواضيع الشائكه اللي احنا لسه ما نقدرش نبراكتس فيها. والف الف شكر لحضرتك يا بيه، متشكرين. شكرا.
Thank you so much for such a nice presentation about the effect of the religion on infertility. I did mention that yesterday in my presentation. In 1999, Imam Khomeini has released a fatwa to say, or to legalize third-party donation in Iran. Plus that Iran is #1 in transgender surgery internationally. So. In South Africa, we do have something else. It's a little bit different, but we have to mention, as we are talking about infertility in general, and this conference is an international conference. So in South Africa, we have milk donation. So the HIV positive ladies or HIV negative ladies donate their milk to HIV positive babies, or actually the HIV positive mothers and HIV negative babies. So from religion point of view or Islamic point of view, we cannot accept that, since we have mother, I don't know what we call it in English, الأم من الرضاعة. So we have to consider that as a barrier for using something or using considering a religion as a part of the infertility. Then we have to consider more researches, more discussions, more studies about the effect of the religion on infertility in general. Thank you so much.
Can I ask a question?
I think all of you know Professor Edward Bob, the first man who ran the program for test tube baby. Edward Bob tell us in the celebration day 25 in the meeting that the church was against insemination completely to do such highly valuable and proved to be promising for many couples. فالصدام بين الشريعة والواقع actually need explanation. أشكر الدكتور. إحنا مسلمين سنة. الشيعة ده قصة تانية بعيد عننا، وفي حاجات كتيرة خالص مش في المستحدثات الطبية ولكن في الطقوس الدينية، فيجب ان احنا تكير. وبعدين اللي بيحكمنا قل ولا تقل، ربنا قال ايه والرسول قال ايه. سيدنا عمر بن الخطاب كان بيلوك for the black stone in the holy Kaaba and say والله I know that you are not benefiting me or injuring me. But I saw Rasul Prophet Muhammad sallallahu alayhi wa sallam looking for you and I am doing what he was doing. ده تعاليم دينية ما فيهاش هزار. شكرا.
يا دكتور.
Thank you to all the presenters. It was very interesting lectures. My question is to Dr. Amal. I just want to ask, I mean, I saw your figures. How did you control for the efficiency of the technique? Or let's say the efficiency of the doctor So I'm sure that every doctor has his own talent. So if you're saying that we harvested that much of embryos in a particular day, or how do you control for these figures that you've given?
What do you mean? Sorry, thank you for your question, but what do you mean exactly?
Like, for example, my efficiency as a doctor might not be like yours.
Yeah.
You know, you might be more efficient than me. Then how do you control for that in your results? Did you have the same doctor doing all these procedures?
Yeah, this is my study. I do it by myself. Yeah.
Oh, so you did it.
Yeah,
all.
already
Okay,
I
thank
do
you.
it by myself. Yeah.
It makes
I follow
sense
my
now.
patient in my OPT regularly on
Yeah.
databases and
So-
recommended every case daily by daily, reported in computer, all investigation, all the result, so that everything gets ready and summarized
So
by statistical package of social science version 25 and
Yeah,
do
okay.
statistical, all the other statistics.
Thank you. Thank you.
السلام عليكم. مشكورين جدا على المحاضرة الرائعة هذه والقيمة. سؤالي لو تكرم البروفيسور محمد ولو عنده إجابة يجاوبني. In our countries we are suffering from the type of patients who are, most of them are advanced maternal age. The main problem we face is the oocyte count and quality. We know the oocyte aging is mainly due to mitochondrial function. In UK in 2015, they allowed or they signed the permission to make a mitochondrial donation for some patients. Can we do mitochondrial donation for our patients as advanced maternal age with the poor quality oocytes, so we can use the genetic material, the nucleus of the original mother, the DNA, and the genetic material of the father, and we just use the mitochondria from young oocyte of young other patient, I mean the donor. So we know that mitochondria contains a fraction of DNA. So I just need the idea or the رأي الشرع في هذه النقطة, يعني in this point, as we are not allowed for gamete donation, embryo donation. So we
I
can
am not
help-
faqih. I am a gynecologist. But I am a Muslim man trying to do my best.
Yes.
What is Allah and the Prophet Muhammad, peace cited upon him, what they are saying. And what I translated, not my opinion.
I
ده
understand.
من مجلس الفتوى الإسلامي ومجلس الدراسات الإسلامية قايلها في أول سلايد. الدراسات الإسلامية بدولة الكويت ودول أكبر 2 تشريعيين بمشاركة الأزهر، يعني اللي بيعملوه لازم الأزهر في مصر يوافق عليه، هيئة علماء من جميع الدول الإسلامية. لكن third partner in the marital relationship is completely forbidden by any means.
Even mitochondrial
Even
donation, I mean.
mitochondrial. What is cloning? Cloning, not nucleus.
This is different from mitochondrial donation.
نفس الكلام. Third partner. Third partner.
But this is very small fraction of
والله
DNA
هو أنا
in
مش
the
أنا
mitochondria.
تقوليها لهيئة
I'm trying
العلماء.
to help our patients. That's why, because our religion forbids the oocyte and embryo donation, and we have the main problem. I don't know why most of our patients are advanced
لكن
maternal
I
age.
can answer you علشان delayed age of marriage.
Yes.
في دلوقتي البنات كلهم in young age ممكن يعملوا freeze of ova. يستخدموها بعد كده بقى ويستخدموا السورجريت مازر، يستخدموهم هم الرحم بتاعهم هم، لكن وده من الانديكيشن، من الفاليد انديكيشن، نوت الانكولوجي بيشنت اونلي، ولكن الديلايد ايج اوف مارج. ففور سيفتي ممكن يعملوا الحكايات دي، وانا شفتها في بنت واحد صديقي فارماسيست. شكرا.
شكرا.
Dr. Ihab,
أنا اللي هقول لها حلال ولا
thank you
حرام.
for this clear presentation. And it was very clear for me and simple, and thank you for that. I just have a small question. During the slide where you said about the details of a dual stem, you said that when you trigger and you have one or more oocytes, you do the pickup and then you do IVF or ICSI. So what's your experience there in Ireland doing IVF
for one oocyte versus ICSI?
Thanks for the good question. We usually don't do IVF for one egg, to be honest. We mention so because there are certain centers, like for example in Europe, in which they need certain approvals to perform the ICSI, and that's why they go directly as being licensed for IVF. But ideally, and according to what we work with and our experience, any poor responder will go direct to ICSI without questions. This is what we recommend, but sometimes we are squeezed in the legislation, and for example, that we cannot do, then we have to go for IVF. Other than this, there are patients who are counseled, depends, could be from Google or whatever, of which they do believe that ICSI is a very invasive procedure that might be affecting the health of the baby, and that's why they request by themselves to do IVF. That's why I mentioned IVF or ICSI. But for me, what to recommend? Direct ICSI procedure.
I have a question. Professor, I have, thank you that you are here in Libya. What was a lovely presentation.
Most welcome.
Poor responder, low AMH. Do you have any experience with PRP? I mean in Irish.
PRP until now, until this date, cannot be proved by any scientific data. All the results of the PRP are according to experience and anecdotal reports, but no scientific value to it until today. I hope we do. I hope we get so soon, not because I'm performing it or I'm a fan of it, but maybe we can make people's life easier, if could be. But until now, nothing proved. You're welcome.
Okay.
Okay, thank you. So that brings us to the end of this session, and it's the final session for today. We will now move on to the closing ceremony for the conference. First of all, I would just like to note that the certificates will be sent electronically within 10 days. If there's any inquiries, you should email the panel. In addition to that, if anybody requires a hard copy of the certificate, they could also email the panel. Moving on, I would like to invite the conference chairman, Professor Muhammad Al-Mheshi, to the stage to give his closing remarks.
So, thanks God, we reached to the end of the Congress, not the end of the discussion. You can't discuss and continue anywhere with now easy communication. So anyone from the speaker, and they are quite happy to ask him and his subject, and they are very nice and very good. So first, I want to say thank you for all committees without any, it's all. I don't want to even name one. They work very hard in short time to bring to this Congress. It is fruitful in my estimation and good, but I want from you what you say. And the co-chairman, I think he wants to make a remarks about our Congress. Thank you to the pharmaceutical companies who support our Congress, and mind you, without them, I think will never be. So thank you for them. Thank you to Noor Al-Hayat. This is the basis hospital, and all the activity and the support coming from them and the organization with the company. thank you for all attender, because without the attender, without you, it wouldn't be the Congress. Without your activity and discussion, it can't be. So thank you for you all who are here now and who even left, but he was here. Thank you who make to people who make really the Congress very fruitful, very nice. Our guests, our professor from everywhere, and you know, and really everyone work hard and give his opinion and his effort. Thank you for our local doctors and professors who make hard to just reaching to the quality of scientific meeting. I will say it is almost same like any Congress anywhere in the world. Every Congress has good points and bad points. So really, I say, without all of you, it wouldn't be this. In the end, I'll say, thank you, thank you, thank you, and we'll meet again, but I have an announcement. Before that, you are welcome to our next meeting by the Fertility Society, Libyan Fertility Society, in 3rd of March 23. So 3/3/23. We choose the music date. And all of you, our guests and local people, prepare yourself for, we like to go up more. So for fruitful and nice Congress, and our local doctors and professors, prepare yourself with nice paper from now. You have time, and I'm sure some people, they have even. So I have nothing else to say. Just enjoy the time for today, and tomorrow I think there are workshop, so still going on, but this is the Congress is finished. This is post-Congress. Thank you. I will ask, if you allow me, the co-chairman to say a word and to give his assessment.
Thank you. That was Conference Chairman Professor Mohammed Al-Mhishi. Moving on, we will ask Professor Gerard van der Horst, who is the co-chairman of the conference, to give his final closing remarks.
Thank you, Professor Al-Mhishi. I want to start off by saying a big hand to the chair, Professor Al-Mhishi. You always need a person of good reputation, of high standing, to be heading a situation like this. Otherwise, it means very little. Because really, what really means something in science, whether it is clinical science, whether it is pure science, always boils down in the end to how's your record looking like. I always tell my students, there's something that nobody can take away from you, and that is your peer-reviewed papers. Let's get to the conference. First of all, I want to indicate something about what's going to happen to the abstracts that everybody has submitted. I can just mention a few figures, and that is there were approximately, and I may be wrong, 1 or 2 here and there, approximately 20 keynote speakers and round about the same number of oral presentations. And as I said initially, I was very impressed by and large, by the standard of these, coming from all parts of Africa and also from other parts of the world. And so let's give those people that have presented a really big hand. Secondly, a total of 66 papers were submitted, and I again speak under correction, but together with those plenary papers or the keynote papers and the oral papers, many of those will be actually published, and I just want to say a few words about that. It took us some time, and I had a little bit of a role to play in that, because I happen to know the editors extremely well of Reproduction, Fertility and Development, which is a very reputable journal, and they have offered to publish all of this. Hopefully by the end of the year. We are in the final process of screening some of these for editorial comments and so forth. And of course we had to pay, or the organization, the conference organization had to pay for it. But what is very comforting and what a lot of you will appreciate, 2 things from this. Number 1 is that it will appear online free. Normally the papers in this journal is not free. But for this conference, all the abstracts will be free. That is the first point I want to make. And the second point is that these abstracts will again be put together almost in a book form and be made available to, I don't know how many copies, Salem told me, but quite a large number of copies. So you will also have it in the printed version, and that is why we haven't had the abstracts printed in an abstract book. So it will be much more formal, it will be much more representing what we have done. Then I just want to come again to the conference and the impressions. Salim asked me to just make a couple of comments. I've already given you an indication of how surprised I was, first of all, by not the hospitality. I know that would have been great, but I emphasize it was wonderful, meeting all the people, taking so good care of us, having such a wonderful meeting with such a wonderful amenities. I mean, I agree with what has been said by Professor Amashi. This compares to, I'm sure all of you that have attended international conferences will agree with me that this is standing as a top conference. It can become, as I said during the first day, one of the conferences on the circuit, the big international conferences, and I think we need to support it. I will personally make it my work, and my colleagues sure will do so, to advertise this very widely and tell people to come next year. And I hope to see all of you here next year to this illustrious conference. Then I'm going to do something which I was totally forbidden to do. And please forgive me. The first part is, I don't need to be forgiven for that. That is to say, you've had a magnificent local organizing committee who's done a fantastic job in a short while, and they need a real big hand. And there are so many exceptions and so many good people in that that it would be unfair to mention names, but I don't think you realize the work that has been done in the background. And unfortunately, you mustn't be mad at me. Salem, Salaway. And Abdullah Aziz, Balash. They've done absolutely amazing work. And the one person with whom they've been in contact all the time and who's done, I promise you, all the editing of the program, all the corrections, sitting nights through, is Dr. Liana Maria. I hope I have not forgotten anything else. I think we have more or less covered everything. if I have not covered or thanked people for what they have done, I also want to thank all the support staff, all the camera people, and also this wonderful man. He has done a great job. Where is your partner? Or that helped you?
She had a small problem.
Oh.
It shouldn't be a problem.
Well, can you tell her also, we thought she was very good. Thank you.
I will do.
If there's nothing else that somebody want to add, perhaps, that I should have added, I don't know. Ralph, Liana, Sahar, you think I've missed out anything important? Okay, they have actually reaffirmed what I said about Salem and yeah, please do that.
Yeah, from my side, I can only say it was excellent, and it would just be additional time for everybody to say more, because everything has been said, and yeah, it was really excellent, and there's an excellent start of more conversations, of more collaborations, which I believe should be done to actually expose this part of the world much more, to bring it up much more, and to make it more visible.
Thank you, Ralph. Don't you want to add anything? Okay, thanks very much. Perhaps Salem just asked me to mention one more thing that I've forgotten, and that is that when we have the conference next year, that when people are presenting their abstracts and so forth, there will again be a selection for probably keynote speakers and oral presentations, but then there will also be a choice for full-length papers. So that is a next step which will give more credibility. Thank you very much.
Thank you, Professor Gerard. Moving on, it's my greatest pleasure to invite the conference founders, the people Professor Gerard has spoken about, the people behind turning this dream into reality. Could you please welcome to the stage Dr. Salim Shalawah, Engineer Abdul Aziz Bilhaj, Dr. Ahmed Al Yaqoubi, Dr. Sulaiman Al Jabri. Could you all please join me to the stage?
Assalamu alaikum wa rahmatullah. First of all, I want to thank all attendance people that came to this conference, and I would like to thank for all our guests and our professors that came, that have a long trip to arrive to Libya. Some of them arrived from 3 days, some of them arrived today. So thank you so much for this long trip to arrive to Libya. Then I will thank all our local committees and professors that worked hardly with us to make this conference like what you say. معلش ممكن نتكلم شوي بالعربي. حابب نشكر أولا الدكتور محمد المحيشي على البروفيسور محمد المحيشي على مساعدته الكبيرة لإنجاح المؤتمر وليكون بالشكل هذا. ثانيا اللجنة العلمية اللي ساهمت معنا مساهمة كبيرة في إنجاح هذا المؤتمر. ثالثا والأهم زملائي وأصدقائي اللي كانوا فعلا يعني في المستوى من 6 أشهر إلى الآن. الشغل أكثر من كبير وأكبر، يعني شغل عظيم جدا اجتازوه أو صنعوه في فترة قصيرة جدا، فلهم جزيل الشكر. أشكر الشركات المساهمة والرعاة الرسميين والرعاة الماسي والذهبي للمؤتمر، شركة الميرك وشركة فيرينج، شركة الاهتمام، معظم الشركات الأخرى اللي ساهمت معنا، لأن زي ما قال الدكتور محيشي لولاهم ما قدرناش نوصلوا للليفل هذا من المؤتمر. أترك الكلمة للدكتور سالم يتكلم على بعض التفاصيل الخاصة بالمؤتمر.
Finally, I can talk now. Before I think to start to think and to talk, I think the presenter, Dr. Muad, he forgot the fifth one from my team. Fatima Atresh, she is engineering. Can you welcome with us? Fatima, she is engineering. She was with us before, I think, 2 years ago, but she is work everything under the table. She is always do double check with everything, especially I think thing. So I don't know from where exactly I can start. Even for my presentation, I didn't mention my name. I guess more than 80% from these people doesn't know me, but I think they maybe know me as I move a lot and what I did. And why I always, rest of my time, I still hand this one. Because everything is in this form. While I am sitting under that chair, I am still doing very hard job. That's why this conference is still see it from different way. But no one he can work as a single person in this world, as we are a human being. No one he can reach his goal if he said, I am from this country, or I am from different religion, or I am different even disability, or different topic, or different anything. So it is really, really, I would like to say thank you for everything and everybody without special anyone. What we did so far, it was really, really very hard. And that is not easy to reach to this point and to say for everyone, we are just a start now. We are just a start at this point because we are planning to do something for 2023 next year. But we can't reach our goal without to have local people, international people, because what I learned from my professor, Rafael Henkel, he is my second father since 2010 at South Africa, and he learned me, he is today here to support me. He told me, Salim, if you like to do nice publication, to finish your master, you should work with the team. Don't hide your work. Since that time, I work to start to design something for, not for Libya, but for all the Arab countries, especially in Africa. So today, really, we are doing something for a human being, not for the Libya only. Our conference, there is a lot of people, they look at from different way. We are not doing something for any name or special someone or anything. We are doing something to start exactly to see the true thing as the research, what he said, for the clinical trial research, systemic review, Cochrane review, all these papers and how the people, they fighting with the language research. How we can connect the outside and inside people without this big gap. Doesn't that mean we have very wrong and that is, we have poor surface? No. That is mean that is growing every day. Even right now, like Dr. Ihab, what he said, even right now, he exactly mean that, even right now. Every day, every single day, we have a new research, new publication. But on the another side, all the clinicians, let us all the clinicians, especially in this area, we have different job for them. They haven't that right time to read the last publication. But we have another problem. If I read anything, I shouldn't go to just to Google and I go to PubMed and I should go to Science Direct. No, there is a new engine research each day and how we can play with this one. That is very difficult to be author and review in the same time, and you do your job at the clinic. That is not easy to change your protocol according to last research. That is not easy to choose the best journal between 42,000 journals according to SJR. That is not easy to see which the conference. That is not easy to go to Congress and to leave some symposium. That is not easy to choose the right topic and to work with the time very hard before anyone he do something already is done. On another hand, we have always money problem, fund problem. That is the Prof. Henkel, always he say for me. When you be at the lab, be careful with any protocol, because like just example for DNA fragmentation, he know how that cost, that and how we can't do it. That is not easy. But we have more than this problem is. A human being behavior, different culture, communication with the people. That is more difficult, this one. If you found yourself with the problem every day, how we can move and forward to second point. There is more challenge, this one. How you can be in the stress and you work with the people like you are so funny. We have always family. We have always problem money. We have always problem right now, but how we can move forward. So I know everyone here is tired. I would like to start thank with the international people and the local people. Professor Mheshi, you are such great professor with every guidelines, with every phone, but you will have some love now when I show you something. He would like to tell me, I'd like to phone you each hour. During that day, I was under pressure, really. He told me, no, I am at Germany, I am at Istanbul, you should answer my phone. During that day, I was doing different things. Me, Dr. Abdulaziz, Dr. Sulaiman, and Fatima. And we are in the big challenge, biggest challenge. The biggest one, we was planning to do everything in the different venue that is called Rexus Place. But before our conference, 2 weeks, they inform us that there is electric problem. We change everything. Within 15 days to be in this stage, with only these 5 people. We have really Noor al-Hayat team, but really that is only with these 5 people. To go more surprised, because I am not afraid, because I am with 2 fathers now. My Mheshi, he is my father, and Professor Naik Henkel, he is like my father. So we didn't get any fund from any governmental. We are doing rest of our work more than 80% even from our money pocket, and working more than 24 hours, 7 days to reach this goal. So I will explain quick about this goal, and before this goal, I would like to thank my foreign people to start from the last one. He just arrived this morning, Professor Ahmed Nasr from Egypt. And can you greet one? Can we greet him? Professor Ihab from Ireland, was difficult to arrive here. Professor Mohammed Salama from Egypt. Professor Obakar Najjar from Egypt. Professor Yasser Yunus from Egypt. Professor Rafal Henkel from UK. And his wife Sharon, Ralph Henkel also comes support him from UK. And Professor Sahar Abdul Rasul from South Africa. And Dr. Intisar from Dubai. And Dr. Anfal from Dubai. Her husband also, Anas from Dubai. Dr. Nazik from Sudan. I think that is all my guests. I didn't forget anyone, is that right? Dr. Abdul Basit Sasi from South Africa. And Dr. Abdul Manan Balik from South Africa. I didn't forget you, Prof. And Lina Mari. Really, she understands everything. She was really support me since last April when I sit with her and explain everything with her. Lina, I don't have fund. Lina, I have this plan. Lina, what we can do? She did a lot for me. She responded my email 24 hours. She did a lot for me because that is not easy really to reach this peer review and to put it in our publication with our journal. Professor Van der Host is big thanks for you because really you did hard job, especially with peer review journal. Thank you, special thank you for them. I would like also thank you all the local people, for certificate people, or maybe Professor Muhammad Abu Dabbous, because he was support me with his team also to review something. I don't like really to have like a special thanks for Professor Mheshi because everyone he know what he did for us, for me, really, really was my inspiration for everything, especially for the time. So big thanks for Professor Al-Maheshi. I will give a quick, short presentation. While I'm sitting right now, I prepared for just second minute because I was unable to prepare this one because I was unable to be here for a lot of reasons. But for the another reason, we should be here now. So we will have funny thing quick. Let's start from one. About ENAF 2022, all the work was done electronic. We mentioned that a lot by Facebook because in our culture, they're working with Facebook more than website. I give a lot before when I did my local presentations in the research in different cities here. We should work hardly during the website, not with the Facebook. The work, everyone who went the website, he's registered with me here. We have now 548 registered people with us inside the country. I think more than 20% outside only. So now we know everyone with his email, with his phone. So that is so easy to contact them and so easy to understand each other. That is very difficult to let people understand this hard work during 3 months, during this all challenges. Next one. And also for accept abstract, also we did something special. If you go to our website, you found as a guideline. Some people don't understand that is guideline, that is not Dr. Salam or Dr. Moheshi or Dr. Abdulaziz or one from us, he put it. No, because we choose one journal. Dr. Liana, she understands what does that mean, choose one journal. That is mean a lot of email with them, a lot of decision, a lot of Zoom meeting. So they have special guideline. I should put that guideline in the website. I mentioned that a lot for anyone, because we reject more than 20 paper, so that's why I should explain this one for the people to encourage them more next year to submit with us. So we have 61 submit abstract, not as a full paper. We accept more than 22 as a poster presentation, 19 as oral presentation. For next year, as the Prof. Van der Host, he mentioned, we will have as a full abstract with full paper conference online paper. Next slide. Everyone, when we go to his slide, we will find his name, like Dr. Nazik, even from Sudan. Even she is speaker, she registered, so I know her, which center, which city, her email, her phone, and also I contact her with her number, like ID number here from up. So her number ID 378. So everyone who contact me, even with WhatsApp or the email, always I ask him, give me your ID number. So everyone he has ID number. Next step. We have, this is our website. We have long time. I didn't forget the people even to start to design our logo and our website. So this is our website, like any international website. We have homepage about conference, about speaker, about award, about registration and submit abstract. That is two very important tool for anyone. If you like to see the registration, always there is early registration and the late registration, if you like to save your money. And submit abstract, always there is deadline and guideline and how I can prepare myself to be as an oral or poster. Next one. Also, we put something in the welcome message with a special video to let the people understand more where we are going and what we are doing. Because anyone in the website, if we see short video more than 40 seconds, he will understand more better than to write anything. Before. Also, I have thank SPC, Security Protection Company. Big thank for this company, please. This is local company. They have a partner, his name Tony. He came from London to meet with us at Nur al-Hayat Fertility, and he is guide us since last May how we can let this international people, they get visa in their passport and how they help them to be arrived safely. And we have their team around with us to make them more comfortable. Doesn't mean we are in the war country, because everyone now he understands we are safe. Everything in news that is different, but we should thank this company. We always have program. We always have everything. That's why when I would mention in the Facebook, in the WhatsApp, please see the program, please see the program. Everything, the program is updated. Anyone as an international conference, the program is updated until the day we start. So that was very, very hard because a lot of complaint I was received with the email and WhatsApp. Where is the program? When the program it will be ready? So that is very good chance for me to explain it for the next year. Everything in the website, everything in the program it will be ready before the conference a few days. Next one. Even the open ceremony was changed from morning to 1 o'clock before the program within 2 or 3 days. As anyone he decide even to go outside the country to have a conference or symposium or a congress, the program is the right way to understand where you are going. The next one. We have this email. Everything is archived and recorded in this email. We have full data. Anyone from you, he submit for me, who contact with me, we have this email. That is like archiving. That is the best way to contact us. And one day, when I opened our website, we found the service unable. Before the conference, 5 days, this is the screen blank. During that time, Professor Mheshi, he phoned me, he was at Germany. He said, Salim, everything right? I said, yes, exactly, is right. That is mean I can't open my email, all the data on it. The problem was with our company, Ribbon Spider, for all the country, for a few hours, but we was very, very stressed. But finally, we worked hardly, because I need to breathe when I walk outside. Worked hard really, because during that time, even Lima Marishi still email me in my email. The journal still need with us. The journal need with still us. So, but we go forward. This is our journal, Reproductive Fertility Development. There is different journal around the world, because the right track for us as a researcher, we should follow only peer-reviewed journal. So this is the peer-reviewed journal, Australia journal. Prof. Van der Hoos, he helped us, because his editor, Chief Martin, his friend. Now we have full approval from them to publish our publication before the end of this year. So any of you, he has submitted his abstract, oral, or poster, or the speaker, he will be in this journal. And this is the publisher, our publisher, also Australian publisher. CSIRO publishing, he's publishing with different disability department. They will publish our work. Until now, we're still working with our website. Anyone who would like to ask any our guest or anyone, we still have this one is still open as registration and communication. We have put your name, please, and put your city, but two important one is your email and your phone. We're working hardly to respond. There is no one who respond him more than 24 hours in the email. So that is really, really big challenge for us. For the next year, that is as international conference, because Professor Van der Hoos as his co-chairman and Professor Muhammad Al-Maheshi as his chairman, he advised us, we set the plan for next year, early this year, because this one, just like we start to test it out just as a promotion. For next year, we will have as an abstract book with the full online conference paper. You are more than welcome to submit any kind of your publication, start from case report until review report. So I would like to thank again all my team and thank you for all you. And now we will start something, explain it quick for us with this video.
Thank you, thank you.
Last thing, I leave it for last thing, just I want a little bit small thanks for Noor Al-Hayat Clinic, because it's the host of this conference. From the first, it was idea, just idea. It's the host of it, and it gave us full support for this conference. So thank you, Noor Al-Hayat Clinic, for all of this support, all of this. Thanks. Last thing, just I mentioned Sharikat Al-Arabi company that's the organized of this conference. So thank you, Al-Arabi company.
Thank you, ladies and gentlemen. Every journey must come to an end, and unfortunately, this is the end of our journey. We hope that you have enjoyed your time here, and for our foreign guests, I hope you enjoyed your time in Libya. We hope you have, all the speakers have succeeded in shedding light of the important and latest advances in the fields of fertility. I don't want to keep you any longer. I was your moderator, Dr. Muad Abu Daber, and I hope to see you soon. We will play now a video trailer of the conference. Thank you.
It's the hope that brings us together to make what is thought to be a miracle come true. Making and changing lives that want to continue to be a part of this world. With the tremendous advancement and significant breakthroughs in the field of fertility, it is our honor to hold the first Noor al-Hayat Fertility Conference in Libya. Be a reason to start a new life. Having a variety of unique places, historical sites and traditions, we welcome you to Libya. Prehistoric sites, which have some of the earliest records dating back to 8000 BC. And then the Phoenicians and Greeks came along and built one of the most important historical cities, the lost treasures of the Roman Empire. The diversity in people, food, and culture that would make you feel like you belong to this place. And we are all connected. We hope you enjoy your stay. Welcome. At weddings, family and loved ones greet the groom and bride, wishing them permanence in their love and bringing to life what bonds them all together. Let's make their wish come true. By holding the first Noor al-Hayat conference in Libya, it promises to return a great value to the medical community by gaining connections with the pioneers in the field and hopefully to level up and shine a light on the ambitious and hardworking doctors in the area. Hosting more than 20 international speakers and covering more than 15 topics. With 8 workshops, gathering from all over the world, you're joining with pioneers from Stanford University, University of Toronto, University of Cambridge, University of the Western Cape, Johns Hopkins School of Medicine, University of Western Australia, Aarhus University, Royal College of Physicians, University of California, San Francisco, Mohammed bin Rashid University of Medicine and Health Sciences, Stellenbosch University, Cairo University, Cicero, Art Fertility, Gardens Hospital, Health Plus Fertility, all together in one place. See you next year in 2023, coming back bigger, better, and with more exciting discussions. Welcome to Noor al-Hayat Conference.
Maybe you're hiding beneath the pillow, and when I'm sleeping, you sleep.
Schönen guten Tag. Heute wir sind in Hauptstadt Tripoli in Libyen. Ich möchte gern bedanken für unsere Gäste aus der ganzen Welt, aus Südafrika, aus England und aus Irisch, aus Australien, Egypt, Sudan und Emirate. Das war wirklich ein fantastischer Kongress, dass wir hier in die Hauptstadt Tripoli von der Al-Hayat Center für den Kinderwunsch sehr begeistert, dass wir hier die Idee tauschen von den differenten Referenzen aus Südafrika from different point of view. Das war sehr gut zu präsentieren hier in der Hauptstadt. هذه كانت كلمة باللغة الألمانية للأجانب اللي يتكلموا باللغة الألمانية اليوم موجودين في طرابلس. سعيد جدا اليوم باختتام مؤتمر نور الحياة الأول للخصوبة في طرابلس ليبيا. كان يوم رائع جدا. 3 أيام كانت مفعمة بالعلم وتبادل الخبرات على مستوى العالم. اليوم نقدر نقول لكم إن ماشيين في خطى ثابتة جدا. نحب نشكر الشباب اللي قاموا على هذا المؤتمر. نبوا نركزوا على بس جانب معين اللي هو جراحة التنظير في علاج تأخر الحمل، اللي هي إن شاء الله حنتعاونوا عليها بقدرة الله إن شاء الله في الأيام القادمة وفي الأسابيع القادمة في معظم المدن الليبية. المشاركة العلمية من قبل الأطباء كانت رائعة جدا. سعيد بوجود اليونج جنريشن. هذا كان عرس من الأعراس اللي مثل ليبيا خير تمثيل. الحمد لله رب العالمين. قدر الله أن يكون النجاح حليفنا. السلام عليكم ورحمة الله ويومكم سعيد.